الوسواس الخناس الذي يوسوس في صدور الناس من الجنة والناس. الله العظيم. Dr. please.
I am Dr. Adiba Javed from the Surgery Department of Hameed Latif Hospital, and today I am truly honored to host this session. Obesity is one of the biggest health challenges for our time, and bariatric surgery has become a powerful and life-changing tool in managing it. Today's session is all about understanding that journey, not just the surgery itself, but everything that surrounds it: patient selection, medical management, nutrition, post-op care, and more. We have gathered some of the most knowledgeable voices in this field, from surgeons to physicians and nutritionists to surgeons. And we hope that by the end of this session, you will walk away with valuable insights that can enhance your understanding and your practice. Let's begin our journey. To start things off, I would like to invite Professor Dr. Javed Raza Dedi Saab, Professor of Surgery, Hameed Latif Hospital, to open the session and set these discussions.
Bismillahirrahmanirrahim. On behalf of the Department of Surgery and Hameed Latif Hospital, it's a privilege to welcome you all to this session on bariatric weight reduction surgery. Weight reduction surgery or bariatric surgery or consciousness about weight is something which started in the 20th century but has come to the forefront in the 21st century. And in the United States of America, bariatric operations or laparoscopic bariatric surgeries have overtaken laparoscopic gallbladder surgeries. That is the magnitude of the problem that we are dealing with. Now, nutrition has very recently become an important part of segment of surgery. When modern medicine started in the late 19th and the early 20th century, the concept in most surgical encounters was to stop feeding patients, keep them nil by mouth, and let the body recover on its own. The concept of nutrition was very poor. It was never recognized. And surgical wards were full of starving patients, right up to the 1980s, when recognition of nutrition as an important component of healthcare was first noticed and was first recognized. And it has become one of the most important components of surgical repair. And residents working here in Hameed Latif Hospital know how particular we are every morning at our patients' nutrition. How regularly we discuss enteral and parenteral nutrition. And we have even 2 dietitians on our team who will be here with you this morning, who advise our patients regarding nutrition and early feeding. It's become such an important concept. Unfortunately, there is an organization called DRAP in Pakistan which has not yet recognized the role of nutrition in surgery. So the concept developed in the 1980s of feeding patients with something that was known as intravenous hyperalimentation, where it was recognized that protein breakdown or protein calorie malnutrition is one of the important factors in delayed healing, in sepsis and death of patients. So the concept of giving nutrition through the veins was developed, and it was soon recognized that you cannot give hyperosmolar solutions through peripheral veins. So the whole concept of central venous cannulation and giving fluids in medicine was coupled with the concept of giving nutrition, because that was the only way to feed these patients. Now we've moved away from the concept of hyperalimentation, where about 6,000-7,000 calories was pushed into patients, towards total parenteral and enteral nutrition. And I'll tell you why. The reason is that when you put a patient or a surgical patient under stress, he behaves different to a person who is undergoing starvation for weight loss. या जिस शख्स ने भूख हड़ताल माल रोड पे करके बैठा है किसी के, because those patients who are normal physically and mentally, not suffering from an illness and starve themselves, their body after 24 to 48 hours will shift from burning glycogen from the liver to burning protein from the muscle, a process known as gluconeogenesis. So they lose muscle. Eventually, the body shifts over to a process of breaking down fat known as ketosis, which provides ketone bodies for the brain and sustains. So protein breakdown कम हो जाता है, वो लोग कीटोसिस में चले जाते हैं और आहिस्ता आहिस्ता उनका वजन कम होता जाता है। अगर वो पानी पीते जाएं तो उनका वजन कम होता जाएगा। तो वो भूख हड़ताल में माल रोड पे महीना डेढ़ दो भी बैठ सकते हैं अगर उनको पानी मिल रहा है। And a lot of the concepts of modern diets, which will be explained to you by the endocrinologist and the dietitian, have come from this concept. And you've heard of the keto diet and all these different fats. Our surgical patient who is under stress and trauma admitted in your ward, when he is starving or devoid of food, once he goes into protein breakdown and gluconeogenesis, these patients don't shift to burning fat, so they'd never go into ketosis, because stress and trauma and injury and bacteria release a ubiquitin proteasome enzyme which continues this process of muscle breakdown. So वो जो starvation वाला है वो तो रहेगा, पानी के साथ उसका वजन कम होगा। हमारा जो मरीज है वो अपना lean muscle burn करेगा। So 3-4 दिन में अगर हम उसको feed नहीं करेंगे, there'll be loss of muscle. He will lose his protein. So eventually the effort of breathing also suffers because there is no strength. So our patients slowly slip away into starvation, and that is one of the leading causes of mortality. And till we eliminate the sepsis and the infection, this protein breakdown does not reverse. So हमारा मरीज और वो starving मरीज फर्क है। इसलिए हमें न्यूट्रिशन देने की जरूरत पड़ती है, so that we can sustain or prevent this protein loss. And once we take away all the inciting parameters, protein breakdown should come back to normal. So here was born a concept known as enhanced recovery after surgery, ERAS, कि मरीज के साथ वो सारे काम किए जाएं जिससे स्टिमुलस या स्ट्रेस कम हो ताकि प्रोटीन ब्रेकडाउन ना हो। इस ERAS के कॉन्सेप्ट ने बैरियाट्रिक सर्जरी को बहुत फायदा दिया, because we learn to understand that if we perform surgeries and major operations and we do not disturb the physiology and we do not set off pain and we do not give patients noxious stimuli, the body will very quickly recover and come back to normal. So bariatric surgery ki success ka one of the reasons is learning this concept of enhanced recovery after surgery. So most of my life as a practicing surgeon has been faced with patients who are starving, और हमारे राउंड पे तो हम इसी को देख रहे होते हैं। Even an obese person who maybe would be a bariatric candidate under normal circumstances, when he comes to us with a leaked duodenal ulcer or sepsis or a colonic leak, even this patient, because of the stress, goes into protein calorie breakdown, and we have to feed him lots and lots of it, despite the fact that he has got a lot of fat on his body. उसको भी टोटल पेरेंटल या एंटरल न्यूट्रिशन की जरूरत होती है अपनी इंजरी और सेप्सिस से निकलने के लिए। तो ये तो है एक कॉन्सेप्ट सर्जरी का जहां न्यूट्रिशन इंपॉर्टेंट है और सर्जन्स न्यूट्रिशन को बड़ा सीरियसली लेते हैं, मच मोर देन फिजिशियंस। फिजिशियन के मरीज मैं देखता हूँ कई दिन बगैर खाने के रहते हैं, लेकिन सर्जन वाला जो है वो TPN या एंट्रल में खासे हम पर्टिकुलर हो गए हैं, एंड आई एम श्योर द एनेस्थीसिया एंड सर्जिकल रेजिडेंट्स विल ऑल वाउच फॉर इट। Now, moving on, in the early part of the 20th century, obesity was not a problem. The world was starving. We had 2 world wars. There was shortage of food, and I'm sure you heard of the famous famine that occurred in Bengal in 1945 and 46 during World War II, when food was diverted away from the subcontinent to soldiers fighting in Europe and North Africa. And Winston Churchill is often blamed for the biggest genocide in the subcontinent because of the loss of wheat, which was for the Bengali population, which was shipped to soldiers. So throughout the 20th century, starvation was the major factor which nations had to fight. People were starving. Even in Pakistan up to 1960-61, the yield per acreage of wheat was very, very low. 2 से 3 मन होता था। जब मॉडर्न फूड और मॉडर्न सीड का कॉन्सेप्ट आया तो यहाँ भी रेवोल्यूशन आया। मैक्सीपाक सीड एक आया था, उसके बाद लोगों को गंदम और खाना मिलना शुरू किया। एंड देन विद कमर्शलाइजेशन of food and the food industry, slowly gradually from the 1950s to the year 2000, the amount and the availability of food to people has increased and gone up. Secondly, mode of transportation and nature of work has become sedentary. So in the earlier part of the 20th century, people who had to go out and work and perform hard labor is no more. It's not a machine and mechanical. So we have seen from the 1970s to 2000 a sudden increase in obesity, and figures from the United States show that in most states about 15 to 17% of people were obese in 1970. Today that figure is in some states is 25 to 30, and some it's above 30. So a huge volume of people have now put on weight and gained weight, and that has led us now to this epidemic in the 21st century, which is the epidemic of obesity. And one of the consequences of this is the condition which is known as the metabolic syndrome. And more people are now becoming diabetics or pre-diabetics. And obesity is leading towards insulin resistance and increase in the number of fatalities and diseases and comorbidities from being overweight and from putting on a lot of weight. So after this realization, obviously एक और ट्रेंड भी हो रहा है दुनिया में जिसको मेडिकलाइजेशन कहते हैं, कि बहुत सारे जो आम जिंदगी के मसले मसाइल थे उनको अब मेडिकल सोल्यूशन दिए जा रहे हैं। तो मेडिकल प्रोफेशनल जो है उसका इनपुट ज्यादा से ज्यादा होता जा रहा है इनटू पीपल। एक जमाने में मोटापे को बस एक सोसाइटल प्रॉब्लम समझा जाता था कि ये शख्स मोटा है, ये अपना ख्याल नहीं रखता। अब मेडिकलाइजेशन की वजह से इट हैज बिकम अ डिजीज, सो नाउ यू हैव ट्रीटमेंट्स फॉर इट, एंड दिस हैज गॉन ऑन विद लॉट्स ऑफ थिंग्स। At one time, nobody bothered about menopause or nobody bothered about these things. They were just considered to be normal events of life or living. But slowly, gradually, people have demanding treatments and solutions. So this is known as medicalization of normal life events. और ये ज़्यादा से ज़्यादा होता चला जा रहा है। और आपने देखा होगा कि बहुत सारे मरीज हमारे पास जो आते हैं और दवाई मांगते हैं, at the background when you go into detail, there is something else going on. And they come with the hope कि ये डॉक्टर हमें को ऐसी चीज देगा कि मेरी सारी जो तकलीफें हैं, इंक्लूडिंग घरेलू या जाती तकलीफें, वो भी खत्म हो जाएंगी, दूर होगी। तो there's more and more medicalization. So obesity management is no more a societal problem. जो हमारे साथ बच्चा था मोटा, हम उसको बुली भी करते थे, हम उसको तंग भी करते थे, और हर बंदा यही समझता था कि ये जी इसकी जाती कमजोरी की वजह से ये मोटा है। लेकिन नो, now obesity is considered a disease with certain underlying genetic and environmental factors which perhaps are beyond the control of an individual. तो इसलिए इसके लिए ये आज का सारा सिम्पोजियम डिजाइन होकर बनाया गया है। तो so from starvation we have now moved to the other extreme where we are now treating overweight obesity as a disease. एक जमाने में इसको कहा जाता था कि सेहतमंद है तो बड़ा सेहतमंद आदमी है, और अगर आप पढ़ें इसमें कुछ सच्चाई भी है। आपने obesity paradox भी सुना होगा। You heard of the obesity paradox? There are certain diseases and conditions in which an obese person's outcome is much better than a thin lean. For example, in certain cardiac operations and cardiac procedures, obese people do better than lean people. So please go and read the obesity paradox as well, जो भी mentioned है। Now coming to obesity, so society और environmental factors की वजह से और genetics की वजह से अब weight बढ़ता चला जा रहा है, and now they are starting to discover conditions which are known as obesogenes. You've heard of obesogenes? Now what they've seen is by doing studies on obesity is that even people who are at the bottom end of BMI, even slowly they are putting on weight. So everybody is putting on weight. Maybe it's the drug and pharma industry, the way they manipulate things, but the research and studies जो आ रही हैं वो अब ये शो कर रही है कि हर शख्स या हर नेचर का इंसान जो है ना वो आहिस्ता आहिस्ता weight put on कर रहे हैं. Maybe we'll have to redefine the BMIs for normal people. From 18 to 25 is considered normal. Maybe eventually in the next 15-20 years, 21 to 28 would be the, because we're all putting on weight. Now that could be due to the diet which we're offered. A lot of commercial and prepared food and readily easily available food and carbohydrate. But what they've discovered is that in the environment there are certain factors which are altering the insulin resistance of people and bringing around endocrine failure in patients. And one of the examples they've given is, for example, a lady carrying a handbag which has PVC in it. That could also alter your endocrine behavior and endocrine profile. So a lot of the stuff and material they claim that we use in environment, in our bags and in our laptops and the plastic and these materials, these are behaving as pro-obesity factors. So in addition to whatever food and whatever things you're eating, now they're looking at these factors कि ये सारी चीजें भी सोसाइटी में आपके एंडोक्राइन को इन्फ्लुएंस करके वेट. दिस इज द लेटेस्ट साइंस ऑफ ओबेसोजेनिक which I think we need to look at. Moving on, जब वजन कम करने की बात आती है तो सबसे पहला काम लोग आपको ये समझाएंगे, बताएंगे कि भाई बेटा खुद ही करो, कोई जरूरत नहीं है ये चीजें करने की, ये दवाइयाँ लेने की, ऑपरेशन कराने की. तो अपना खाना कम करो, वर्जिश ज्यादा करो, तो आहिस्ता आहिस्ता आपका वजन कम हो जाएगा. And perhaps diets or lifestyle modification is the first step towards dealing or treating obesity, and the dietitians I'm sure will be talking to you about that. Now studies have looked at this and found that it doesn't work. And lots of randomized controlled trials have now confirmed that in obesity or those with BMIs above 30, bariatric surgery in multiple randomized trials is more effective in maintaining weight loss over 15 to 20 years. It maintains a 15 to 25% weight loss in the following 15 to 20 years versus lifestyle change and diet modification and exercise. And exercise probably is the least important in all this in losing weight. Yes, it will give you a fit heart, it will give you a fit cardiovascular system, it's very useful. But the problem is that when you go on a diet, your BMR falls, your basal metabolic rate falls. And once you come off the diet, you very rapidly go back towards your original basal metabolic rate. So that is why lots of diets fail. And these efforts do fail. And people come complaining that I don't eat, and the dietitian will talk more about it. So we have moved on, and there is a whole segment of bariatric surgery which started in 1990 and in 1990 it was open bariatric surgery. उस ज़माने में ये ऑपरेशन जो है, ये गैस्ट्रिक स्लीप और ये सारे ये लेप्रोटमी से किए जाते हैं. And there is a big Swedish study starting in 1990 and still continuing, which shows that certainly the benefit of surgery above all the other methods for long-term sustenance is there, because ये जो मैंने अभी आपको BMR के साथ प्रॉब्लम बताया है, सर्जरी उसको करेक्ट करती है. In the meantime, the endocrinologist here, now many drug therapies have also come into vogue. Started with numerous drugs. अब जब हम मेडिकल स्टूडेंट थे तो एक दवाई होती थी पॉन्डेरॉल, वो दिया जाता था वजन कम करने के लिए. They were all ineffective, all listed. Now there seems to have been a revolution and the whole world is running after certain drugs, especially क्या कहते हैं GLP-1. So जो आपकी bariatric surgery है वो GLP-1 को भी alter करती है. That's the advantage of it. लेकिन the whole world is now running after Ozempic. Used judiciously, used effectively, yes, it's a very good thing. But people now are trying to use it कि जी मैंने किसी की शादी अटेंड करनी है तो Ozempic लेके पतला ना हो जाए. Not here, even in the West. A lot of celebrities and a lot of stars demand Ozempic because they have to fit into certain dresses or certain style. So the endocrinologist here, he's going to speak about that. So we are entering a different era now. with food and weight reduction and bariatric surgery. And today's session is to talk about the three aspects of weight reduction. Number one is diet, linked with exercise, which the dietitians will talk to you about, food, what to consume, how to consume. A huge amount of myths about food. खाने के बारे में आप जितने प्रैक्टिसिंग डॉक्टर्स हैं रोज मरीजों के साथ एक खाने के बारे में एक ऊंच नीच बहस होती है. एंड ill understood. Do you know that the calories per serving of food were worked out over 140 years ago and have never been done again? एक वो इंस्ट्रूमेंट होता है जिसको बॉम्ब कैलोरी मीटर कहते हैं, उसमें ये मेजर होते हैं, कभी दोबारा साइंटिफिकली ये हुआ ही नहीं है. So there's also misconceptions about the number of calories in food, but the dietitian talk about that. And then the endocrinologist will talk to you about the various drug options that we have and how they work and who to give and what to give. And then the surgeons are here to talk to you about the different operations. Two we have heard of, everybody knows them, gastric sleeve and gastric, but there are numerous other operations and other things available which they are going to talk about. And then we also have one of the very important components to do with the nutrition is the behavior of the respiratory system. And Dr. Islam is here. So I won't take any more of your time. This was just a little introduction about how nutrition is playing a role in surgery. It's a very, very important component of surgery, both undernutrition and overnutrition. So once again, I welcome you all and I hope you will have a very stimulating and a very informative meeting this morning. And I'll now hand over to my colleague, Professor Farooq Rana, who is head of surgery in Hameed Latif Hospital, and he is behind today's organization. This effort is because of the interest in bariatric surgery and weight reduction surgery. So I would invite him to come over here and lead you through all these sessions.
Thank you very much, sir. First of all, I would like to pay tribute to Professor Javed Raza Gardezi. He's a great motivation for all of us, and behind all these CMEs and MDTs, he's the actual motivation that we go through. So thank you very much for patronizing all these activities, and especially for this symposium, it was his direction that we organized. So before I move to my talk, I'll request Adiba. Professor Tanveer has to leave out of town and he has requested, so he'll deliver his talk, so then we move on to our schedule. Thank you.
Now I will invite Dr. Tanveer Salam, who is the Head of Department of Medicine, Hameed Latif Hospital. He is a renowned, he is a physician and intensive and pulmonologist. I would like to invite on the topic evaluation and preoperative management of obstructive sleep apnea in bariatric surgery. Patients, a key comorbidity that we cannot afford to overlook.
Hopefully it comes through. Yep. Obstructive sleep apnea. Physicians कहते हैं जी हम सर्जन से बेहतर काम करते हैं. Surgeons कहते हैं जी हम physician भी हैं और surgeon भी हैं. So that is a very true fact. Surgeons are surgeons and physicians. Physicians are only physicians. But we try to hinder all the surgeries and by saying unfit. So any bariatric surgery is unfit from my point. Moving on, what is obstructive sleep apnea? All the bariatric surgeries that go through, they will have sleep apnea. True or false? 83% of patients going through to bariatric surgery will have underlying sleep. Some of them are diagnosed, some of them are not diagnosed pre-operatively, and those will be diagnosed post-operatively, yeah, right after operatively. Okay. Basically, what is sleep apnea? It's the patient क्या कहता है जी मेरा रात को सांस बंद हो जाता है, मैं खराटे लेता हूँ, सुबह उठता हूँ थका हुआ होता हूँ, सुबह उठता हूँ हेडेक होता है. All of these are plain and simple things that the patients will complain of. But having said that, we should try to figure out these patients, do they have sleep apnea or not. Most of them will improve. Most of them will improve with bariatric surgery. So any patient that is coming to me for obstructive sleep apnea should be evaluated by Rana Saab for bariatric surgery. Any patient going to Rana Saab for bariatric surgery is underlying having sleep apnea. So it's hand to hand. अच्छा जी, central sleep apnea से इतना आपके साथ रोल नहीं है. What is happening? All these obese patients, the circumference, once your neck circumference is 17 and above. I don't see anyone over here with a circumference of 17, maybe one. One of Rana Saab's resident has 17 and above. So what happens is the tone and the muscle tone, all of that, when you go to sleep, also sleeps. As the tone goes down, remember, our breathing will decrease the pressure in the neck. जब हम सांस लेने लगते हैं, so intrathoracic pressure decrease करता है, वो अपनी एयरवे को क्लोजर की तरफ लेके जाएगा. जैसे वो एयरवे को क्लोजर की तरफ लेके जाएगा, these patients have more related to the weight of the tongue, the airway, the whole airway will close. Now, दिन में क्यों नहीं होता, रात में क्यों होता है? It's all related to the tone. These are the symptoms most of us know. How do you diagnose? Plain and simple is the sleep study, the gold standard. It's done everywhere. And it's the gold standard, you can't go without it. A problem here is the expense of sleep study. If you do inpatient, maybe inpatient का मतलब है admit करोगे फिर करोगे. When you do outpatient, the cost of the sleep study goes significantly down. That's the only way to finalize you have sleep apnea or no. History gives you an idea, but sleep study gives you the diagnosis. What is AHI? AHI कितनी दफा एक घंटे में पेशेंट का सांस बंद होता है, कितना बंद होना जरूरी है कि उसको वो AHI में गिनती में आएगा. More than 10 seconds हो और पेशेंट का 10 सेकंड के एंड में अराउजल हो, just the brain arousal, he doesn't have to wake up. All it is his brain is aroused or 4% drop in the saturation. Every time ये हमारा AHI कहलाता है. AHI is 5 to 15 is characterized as mild and 15 to 30 is moderate. More than 30 events per hour is significant. I know I'm just going to go quickly from here on ताकि I will not take a lot of time, but remember sleep apneic, all of these will be on their sleep study. Exact number जो आएगा, that is again 83. In general surgery patients, understand? In general surgery patient, it is 43%, and in bariatric surgery is up to 83%. Macroglossia and retrognathia, micrognathia, these are very few patients, so I'm not going to go on those. Treatment modality मैंने लाल में डाली bariatric surgery. क्यों डाली? क्योंकि that is the final goal. ultimately, what are our options? Dental devices, none of the patients like. UPP, Pakistan, to my knowledge, is not performed. CPAP is across the board, is the treatment of choice, and has been used years and years and years and years. Does CPAP decrease weight? That's $1 million question. The thing is, these patients are in a vicious cycle of increasing weight over lifetime, because all they do is during the day they eat, during the night they are up, brain is up, so they don't have the energy. सारी पेशेंट, जितने भी पेशेंट्स आएंगे वो कहेंगे मैं तो टोटल रोटी इतनी खाता हूँ. मैं सबको एक ही जवाब देता हूँ. If you find one person like you in Ethiopia or Thal, I'll say okay, आपने कम खाना खाया था. There is nobody like you neither in Thal or Ethiopia. That means whatever amount you are eating is more than what you actually need. खाने के ऊपर आगे डिस्कशंस होती हैं. Tracheostomy was one years and years and years and years ago, decades ago. Tracheostomy was the treatment. ट्रेक करते थे, फारिग हो जाते, आगे चलते. No more. Weight loss doesn't work. Bariatric surgery definitely works. These patients, if they start using the BiPAP, CPAP, pre-op, post-op, and then continue, then they also have a better option. Upcoming options are there, but again, they are like upper airway stimulation device. It's a pacemaker for the neck. You just place it under the skin just like a pacemaker, and it is attached to the vagus nerve, and then what it does is whenever the airways is closing off, it gives a stimulus. Rather than the brain giving them the stimulus, this will give the stimulus directly. उससे आगे मैंने वो GLP-1 वाले को छोड़ दिया, लेकिन this has been approved for sleep apnea. जो आपकी है Banjaro has been approved, but not Ozempic. That is under this. Bariatric surgery helps obstructive sleep, reduces weight right away. So the weight comes down, and then the obstruction levels also come down. Improves respiratory function. Patient को समझाने के लिए what I say is your height is related to the lung size, and then the lung size does not increase when your weight go up. When your weight go up, your lung actually decrease. You develop restriction rather than increase in size in the lung. So all of the one, and then you're decreasing the size of the lung and doubling the size of the total body, meaning by you need to work 4 times to do the same job. The adherence, CPAP की जितनी adherence होगी, pre, post and home, they will have a better off lifespan. अब ये एक unfortunate story मैं सुनाने लगा हूँ, but it is a true fact, and this is in US. Patient came for obstructive sleep apnea, history of sleep apnea, and on CPAP came and had the bariatric surgery done. Right after the surgery, the patient was sent to the floor. In the floor, patient complained of pain. Patient was given morphine. Later on, patient was confused, disoriented. She was not given the CPAP. She was already on at home. She developed respiratory failure, arrest, and died. Having said that, this is why I brought this up as the family. You killed my mother. अब मैं इसी चीज को during my fellowship का example देता हूँ. When I was doing fellowship, I was in ICU. I was called to see a patient just like her. At that, I don't know if insurance now covers bariatric surgery or not.
Insurance did not cover the bariatric surgery, so the patient right away after the surgery was sent to the floor. This is a different film. The patient, mine was a different patient. Right after surgery, she went to the floor, where she was given the narcotic. Instead of being drowsy, she vomited, aspirated, developed a pneumonia, came to the ER, ICU, placed her on the vent and whatever not, and then she did not survive. Again, she ended up with, the family ended up, because she's dead, she ended up with $200,000 bill, which the insurance said, we have nothing to do with it. So they sued the whole team, not just the surgeon, the ICU, the everything. Meaning by these things do happen. ये अभी राणा साहब ने सारे मेरे questions जो है ना आंसर करने होंगे. How can we avoid all of these problems? 24 hours right after surgery, they should be closely monitored and placed on CPAP, period. Problem ये है कि I don't believe and I don't think at this point we are how many years, 20, 30 years ahead, कि bariatric surgery is not a contraindication for CPAP or BiPAP. So these patients, if they remember, post-op mein, they may develop hypoxemia, especially if they are lying flat. जो diaphragm है उसका effect, obesity का effect, सारा effect पड़ता है. So the first thing, I hope anesthetists को नहीं बैठा हो, the first thing they will do is give the oxygen. Now, जैसे ही आप ऑक्सीजन देंगे अपर एयरवे की तरफ तो चली जाएगी, अपर लोब्स में नहीं, लोअर लोब्स में उस तरह से नहीं जाएगी, लोअर लोब का एटेलेक्टिसिस बढ़ता जाएगा. That's all that patient needs now. Is now he's a sitting duck. So instead of just going ahead with giving the painkillers and oxygens, at that point, if you use the CPAPs and BiPAPs, we may be able monitoring, close monitoring, oxygen levels and carbon dioxide with these patients may have lesser problems post-operative. Why do we care about obstructive sleep apnea? Again, we care about obstructive sleep apnea is because once you have obstructive sleep apnea, it may be the cause of a lot of other problems now. Diabetes, hypertension, anemia, you name it, वो लिस्ट में मैंने लिख दी. Outcome in sleep apneic patients is worse than non-sleep apneic. There is no doubt about it. उनमें respiratory problems हैं, उनमें pneumonias हैं, embolisms हैं, ARDS. इनके हैं ही हैं respiratory. पहले से स्क्रीनिंग करें ताकि हमें पता हो कि इसको है. इसमें 83% आपके आ गए. प्री ऑप उनको डिवाइस एडवाइस करके इनको उस पर स्टेबलाइज करें, पोस्ट ऑप फिर CPAP को इस्तेमाल करें, एंड देन कंटिन्यू एंड नेवर लीव दिस पेशेंट टोटली सुपाइन. दे शुड बी ऑन एन एंकर. एक्सट्यूबेशन के वक्त से लेके आगे 24 आवर्स क्लोज मॉनिटरिंग एज वी डिस्कस्ड. रैम रिबाउंड ऑन द थर्ड डे. पेशेंट का जो अंडरलाइंग रैम है ना, रैम की स्लीप का पता है कि स्टेज 1, 2, 3, 4 होती है, फिर रैम होता है. रैम में सबसे वर्स्ट स्लीप एपनिया होता है और उनका रिबाउंड आएगा 3 दिन के बाद आफ्टर दिस सर्जरी. सो थर्ड डे कैन बिकम अ मोर डिलीटीरियस फॉर देम. ओपिएट रिक्वायरमेंट को बड़ा जुडिशियसली सोचें. ओपिएट इज a no in these patients because find another way of pain control. चलिए बस मेरा ख्याल है इसी में मैं आपको थैंक यू कहूँगा. Hopefully we have learned a little bit and we'll move on. Thank you very much.
Thank you, Dr. Tanveer. Now I would like to invite Dr. Farooq Ahmed Rana, Head of Department of Surgery, Hameed Latif Hospital, who will give us an overview of bariatric surgery, including how we assess and prepare patients before they go to the operating room.
So I'd like to appreciate Professor Tanveer Salam for giving a very detailed overview of obstructive sleep apnea. If there's any question regarding obstructive sleep apnea and their perioperative management. Yes, Dr. Salam.
My understanding is that is that a full comprehensive sleep study or it's a modified sleep study? Because I've been told that one thing is not as comprehensive as
Depends. You can have to find the comprehensive with all the EEG levels. Always just the EEG level. All the rest of the stuff is in the same. I'm fine with the preliminary one with the oxygen level, the scoring level, the heart rate, and breathing. Remember, what I said was there are belts on the abdomen that showed the patient was breathing, but there was no flow. And with the patient's effort, no flow, hypoxemia, breathing. That's what sleep apnea is.
I think management of bariatric patient is multidisciplinary, and one of the important thing is management of the sleep apnea, and we always need the input of pulmonologist and intensivist. So we are always grateful and we get consultation whenever it's required. And it is selective because in class 1 and class 2 obesity, most of the patients are without obstructive sleep apnea. So we can go ahead without sleep studies. But for super obese, and as he told, more than 17 circumference and with a history of snoring and obstructive sleep apnea, definitely we always have a sleep studies, and perioperatively we have to take care of obstructive sleep apnea. And second advice of Tanveer Salam, now it's a standard practice that we don't use opioid in bariatric patient. During the perioperative management of bariatric patient, opioid-free anesthesia is a concept, and that usually managed with the lidocaine and paracetamol and other form of analgesia. We preferably not use opioids during perioperative management of bariatric patient. And secondly, nasal airway is kept in routine in all patients just to ensure and prevent obstructive sleep apnea. Third thing is the concept of extubation when they are fully awake. So in most institutions where bariatric surgery is done, they are not extubated in the operating room. So they are shifted in the recovery area with the tube, and there when they are fully awake and they can take care of their airway, then the extubation is done. So these are the few precautions, but still the role of CPAP cannot be overemphasized. Definitely CPAP, when it is required, it has to be there. But there is a few studies that shows in upper GI surgery with the CPAP there is a slightly more risk of leakage from the anastomosis. That's the one apprehension with the surgeon. But definitely when it is required, the life saving is a priority than rest of the complication. So with this we'll move to the next talk. So my assignment was to give introduction of the bariatric surgery and its different types, indication, and how actually we, because this symposium is focused for the postgraduate residents, and the idea was if we have a patient, a bariatric patient, how do we actually evaluate it, how we document it, and how we prepare for the surgery, and how we select a procedure, because now there is a variety of procedure available in the market, and every procedure cannot be offered to every patient. And to make it more live, we have requested 2 patients actually. So at the end of this symposium, we will be having few bariatric surgeons with us as well. So considering their history and BMI and their food preferences, we will discuss as well what will be the most suitable procedure for these patients to offer. So first of all, we discuss as Professor Javed Gardezi gave a very detailed overview why obesity is important. Obesity is now considered by WHO as an epidemic, because according to one study in 2022, 1 in 8 people in the world were living with obesity. So worldwide adult obesity has more than doubled since 1990, and in 2.5 billion adults were overweight and 890 million were living with obesity. So the disease volume is quite high. So that's why more and more people are seeking and being referred for obesity surgery. So first of all, we need to understand what is overweight and what is obesity. So these are the recent guidelines by IFSO. IFSO is the biggest body forum that generate guidelines for bariatric patient and obesity patients, and American Society of Metabolic and Bariatric Surgery. So these are the 2022 guidelines and classification of bariatric patient. So a patient who is with more than 25 BMI is considered overweight, and a patient with BMI more than 30 is considered obese. So there are 5 classes of obesity. Start from 30 to 34 is class 1, and 35 to 39 class 2, and then 3, 4 and 5. So now we comes to the guidelines. In 1991, the first guidelines were generated by National Institute of Health, and it was more of opinion based. But now 2020 IFSO and American board guidelines are evidence based, based on meta-analysis, RCTs and level 1 and level 2 evidence. So who qualify for the bariatric surgery? So now the term is MBS. Previously it was bariatric surgery, and now it is MBS, metabolic and bariatric surgery. So metabolic and bariatric surgery is recommended for individuals with a BMI more than 35. If the BMI is more than 35 and the patient has tried conservative diet and exercise and failed, so he can be considered for bariatric surgery. Previously it was 40. So actually the BMI has come down. Previously it was 40, and now in 2020 latest current guideline it is 35 above. And if there are comorbs, diabetes, dyslipidemia, hypertension, ischemic heart disease, so 30 to 34 BMI with comorbs, the patient can be considered for metabolic and bariatric surgery. And for the Asian population, the BMI is still low, because they are considered obese if they have a BMI more than 25, not overweight, obese. And at 27.5 BMI, they can be considered for metabolic and bariatric surgery. So why for Asian population different BMI? In the Asian population, the prevalence of diabetes, cardiovascular disease is higher at a lower BMI than in the non-Asian population. This is evidence-based. So thus BMI risk zone is adjusted to define obesity at a BMI threshold of 25 to 27.5 for Asian population. So long-term data on outcome of metabolic and bariatric surgery consistently demonstrate the safety, efficacy and durability of metabolic and bariatric surgery in the treatment of clinically severe obesity and its comorbidities. So now the mortality rate is less than 1%, in some studies less than 0.5%, despite all the comorbidities and the risk factors. So this is just for the resident. When you take a history and examinations, these are the possible comorbidities that you need to look into the patient. So patient may be having serious psychiatric illness, migraines, cardiovascular, so dyslipidemia and cardiovascular diseases, hypertension, obstructive sleep apnea and asthma, gastroesophageal reflux disease, hiatal hernia, these are also associated with the obesity, stress, urinary incontinence, joints pain, osteoarthritis and backache is a very common presenting complaints the obese patient presents,
In females, infertility and PCO. So this is the main reason for referral to the bariatric surgeon. And lymphedema, venous stasis, lymphedema of the lower abdomen and the lower limbs, and the liver. There are many patients who ends up in the organ failure, liver failure and kidney failure because of obesity. And the NASH is a known condition. First is the fatty liver, and if it is left untreated, the patient progresses to NASH and full-blown liver failure. So these are the comorbidities that you need to look into the patient when you are evaluating a bariatric patient, what comorbidities are present in that patient. And this is just with percentage. If you operate on a bariatric patient, so this is the percentage the comorbidity resolve in these patients. If you see asthma resolves in obstructive sleep apnea in 82% patients. Hypertension 52 to 92% patients are off the medicines. GERD improves in 72 to 98%. Similarly, osteoarthritis also improves in up to 76%. So the idea is there is a significant improvement in the quality of life, because this is what the patient asks, how I'll be benefiting from this surgery. So then you can discuss, considering the comorbidities, that these are the benefit and there's a this much chance that your problems will be better. So why bariatric surgery? Why not medicine? This is the other question patient asks. Doctor, can I not be treated without surgery? Why not diet and exercise? As Professor Javed Gadis told, that diet and exercise is the first thing that you should offer. The patient should always try and exhaust himself or herself that they have tried diet and exercise. The evidence shows only 5% patients have sustained long-term weight loss with the diet and exercise. Rest 95% they have a relapse. Either they fail altogether to reduce the weight, or even if they reduce, then they regain. And with bariatric surgery, up to 75% of the excess body weight loss is sustained. Now again, bariatric surgery is not a cholecystectomy or appendicectomy. It's a package. Patient has to understand and accept. Yes, there are benefits, but there is a change in lifestyle, change in eating practices. There is a regular follow-up that is required. Follow-up with the surgical team, follow-up with the dietitian. The patient should be competent to understand all this. I will narrate just one example. Gujranwala se ek patient aaya, he was morbidly obese, around 150-160 kg, and he wanted weight reduction. He was motivated. But when I discussed and explained that we will make a small stomach pouch and you will be having small meals and liquid meals for some time, so he regretted. He told, I would prefer to die, but I cannot quit my regular meals and eating. मैंने कहा डॉक्टर साहब को दवाई लिख दो, मैं नहीं ऑपरेशन कराना. So this important thing, discussion with the patient should be accepting this and understand that what lifestyle and food practices and how it will impact his life. He should be fully understanding that. And then final question patient asks कि जी इसका कोई side effect तो नहीं होगा, कोई complication का risk तो नहीं है? Yes. So these are the few common complications that you need to risk. Despite everything that we do, but there is a risk of complication that can be managed, but complication risk is always there. Finally, it is not a one-man show. The only bariatric surgeon cannot deal with these patients. These are difficult patients. Right from the beginning, pre-operative evaluation, the dietitian is a part of bariatric team. The dietitian do his or her job, and then the surgical teams do their job. And as I discussed, the patient should be understanding the problem and should be willing to comply post-operatively. In most countries, you cannot proceed for bariatric surgery without psychiatric evaluation. In our setup, we as a surgeon do this job, we evaluate the patient, and if we suspect that patient have some difficulty in understanding or some behavioral disorder, then we refer those patients to the psychiatrist. And similarly, one of the cause of obesity is the endocrine disorder. If during history and review we notice that there is some endocrine disorder, then we take the endocrinologist into loop. And similarly, finally, in super obese, they have definitely some obstructive sleep apnea. We refer the patient to the pulmonologist for sleep studies and for perioperative management. So this is the routine thing in preoperative evaluation. We do all this: education of the patient, investigation, anesthesia, and if any optimization is possible. In certain patients who are super obese, we cannot operate them right the next day. We have to put them on the diet, sometime on the medication to reduce some weight, respiratory exercises. They have a huge fatty liver, and sometime for gastric bypass it is quite challenging. So we put them on diet so that their fatty liver and other things improves. And the patient, actually we put them the diet which will be post-operatively, so that they understand what will be their food practices after the surgery. Now I'll just give a brief overview of what are the common bariatric procedure that we offer. So the bariatric procedures are based on these principles. One is the restriction, next is the malabsorption, then combination of restriction and malabsorption, and then neuroendocrine mechanism. So all the bariatric procedure have some component of neuroendocrine. So there is certain changes in the gut hormones that helps in the weight management. Restriction is in the history. So dental wiring was the first bariatric procedure that is reported in the history, because at that time that was the only way to restrict the diet. In the initial bariatric procedures, this was the most popular bariatric procedure, that was gastric bending. So you apply a silicone band in the proximal half of the stomach laparoscopically, and then you inflate a cuff like endotracheal tube, and it produces a restriction. Due to this restriction, patient is not able to eat much. But there are problems with this. Few people they don't tolerate this, lot of nausea, and ultimately foreign body has a tendency, if you wrap it around a part of gut, it's going to erode into it. So many patients with gastric band, they ends up in erosion into the stomach, either endoscopically or surgically. They had to be removed later on. So this is the now most popular procedure, and in terms of numbers, the number is increasing every year. In sleeve, you remove 70 to 80% of the stomach. You do a staple. So 50 to 100 ml is the capacity of the sleeve, and it's mainly restriction, and then some endocrine component as well, because the fundus of the stomach produces a hormone that is called ghrelin, and that is with appetite. If you remove the fundus of the stomach and extra stomach, actually the craving for food that decreases, and the capacity also decreases, so it results in sustained weight loss. This is the, in terms of number, still in the world the highest number is Roux-en-Y gastric bypass, and it is being done for around 3 decades, so its safety is well established. This is called the father of all bariatric procedures, because even still, if there is a complication with the sleeve or in any other bariatric procedure, you have to convert it to Roux-en-Y gastric bypass to deal with that complication. So what we do in the Roux-en-Y gastric bypass, you don't remove the stomach. You make a small pouch in the proximal half of the stomach, and all of you understand Roux-en-Y reconstruction with the jejunum. You establish the connection with the baby stomach, and this is how it functions. We welcome Professor Tahir Yunus, a very renowned bariatric surgeon of the town. Not only town, he is internationally renowned. Thank you, sir. Thank you for joining. So the other advantage of Roux-en-Y gastric bypass is it is a low pressure system. In sleeve is a high pressure system. When you do a sleeve, if the patient already has some reflux, so usually it gets worse. But when you do Roux-en-Y gastric anastomosis, there is no biliary reflux and it's a low pressure, and actually it is one of the treatment of the reflux. The reflux settles. So this is how, if you understand the basic physiology and principle of these procedures, so you can offer the right procedure to your patient. And third, you can tailor the length of the limb of biliary limbs and the Roux limbs, alimentary limbs. If the patient has high BMI, so then the length would be different. If the patient has class 1, class 2 obesity, then the limb length would, so you can tailor according to the requirement of the procedure. But this is technically demanding operation, Roux-en-Y gastric bypass. That's why few people do it. It is very natural. A complex procedure is not widely practiced. Why the sleeve, the number is increasing? Because it is easy to do and more people are reproducing it. But the problem with sleeve is weight regain is common. After a few years, many people, they start regaining the weight. So then comes the new procedure, that is mini gastric bypass. Why this is called mini gastric bypass? Patient को कहते हैं ये छोटा bypass है, वो दूसरा Roux-en-Y वाला बड़ा bypass है. उसमें 2 anastomosis होते हैं और इसमें single anastomosis होता है. So you make a long pouch of the stomach and you simply do a gastrojejunostomy. This is also gaining popularity and its number is increasing, and now we have a data to support its effectiveness. But the only problem here is the biliary reflux. A good number of patients, after some time when the pouch dilate, they present with a bilious vomiting and biliary reflux. So then how do you manage this? You have to convert it to Roux-en-Y to treat the condition. And the advantage of mini gastric bypass is the gastric pouch is long. Patients are able to eat more. गुजरांवाल वाले पेशेंट मिनी गैस्ट्रिक बाईपास करवाते हैं, वो कहते हैं उससे खाना पीना ठीक चलता रहता है. Second thing is this distance from the DJ up to the anastomosis, this can also be tailored. Minimum is 150, but you can increase up to 250. How much weight loss you want and how much is the initial BMI, you can tailor the length of this. And what are the common problem with these procedures? One is the biliary reflux and other is severe malnutrition. Sometimes the gut length is different in different patient. You have to ensure a good number of small length of small gut from ileocecal junction up to this anastomosis. If that length is small, then patient will present in a very cachexic state, muscle wasting and malnourished, sarcopenic. So then sometimes we have to reverse it or we have to change the length of the anastomosis. And these are the modern procedures for super obese and for patient who present with a weight regain. So this operation is SADS. This is endorsed by the American Society of Metabolic Surgery. So what is this procedure? Any resident who can explain this? In this is technically a little bit more complex. First you make a sleeve like sleeve gastrectomy, you remove the extra stomach. Then you preserve pylorus and you go to the first part of duodenum, you mobilize that part. Then you apply a staple and disconnect the duodenum from this sleeve. And you take a ileum and it should be 250 to 300 centimeter from ileocecal junction, and you do an anastomosis with the first part of duodenum proximally. So the now food goes into the ileum. So these are not the procedures who are offered to class 1, class 2, class 3 patients. These are reserved for super obese and weight regain. Professor Dr. Tahir Yunus will be talking in detail about weight regains and how we select these procedures. This is another procedures. The Saudi was difficult to do. Then the people looked for a procedure who should be simple. That should be simple. So this is a modification of Saudi. Here you don't disconnect the duodenum. You do a sleeve, and similarly you take a loop of ileum 200, 250 to 300 centimeter, and you do a anastomosis at the level of antrum. So this is not an endorsed procedure. People are doing it, and maybe in future. But the problem is again excessive weight loss and malnutrition. The patient, sometimes you have to reverse this procedure. So this is the solution for the problems of both the procedure we discussed before. In the Saudi, you have to transact the duodenum. In Sasi, you are doing an anastomosis before the pylorus. In this procedure, you do a sleeve, and then you take a loop of ileum and you make a small anastomosis with the duodenum. This is called bipartition procedure. In Pakistan, Tahir Yunus and me did this procedure in the Jinnah hospital for the first time. So the advantage of this procedure is that the duodenum is accessible for endoscopy in the future, number one. Number two, you make a small anastomosis. The normal passage of food will be from the stomach to the duodenum and in a natural way. But a portion of food will be diverted to the ileum, because that food that is diverted to the ileum before it follows the natural pathway, that induces certain hormonal changes. It has an endocrine component. It induces early satiety, and it also helps in the weight loss. So this is the routine workup you routinely do for every bariatric patient. I will not go into the detail. Ultrasound of abdomen is done in every patient. Upper GI endoscopy is done in patient who gives the history of GERD. Cardiac evaluation is in selected group of patients. If the patient give on history, the patient is super obese or there is a history of sleep apnea, so then you get the sleep studies and get this done. And endocrine, if the patient you suspect there is some adrenal or other thyroid or endocrine disorder, so you always take the endocrinologist into loop. This is the routine documentation that we do in every patient. You specifically want to know about these comorbidities: diabetes, hypertension, obstructive sleep apnea, GERD, osteoarthritis, backache, any cardiovascular disorder, psychiatric issues, lymphedema, NASH. So these are comorbidities you document in both ways, whether they are present or not. In dietary history, this is also very important, because food preferences of the patient, knowing this help you in making the right choice what you need to offer. तो पेशेंट आमतौर पे उनके दो पैटर्न्स होते हैं, या तो कार्ब्स ईटर होते हैं या ज़्यादा फैटी फूड के लिए प्रेफरेंस होती है। दूसरा वॉल्यूम कितना है, जैसे मैंने कहा ना कि गुजरांवाला में मिनी गैस्ट्रिक बाईपास इसलिए कंसीडर करते हैं कि उसमें पाउच बड़ी होती है, उसमें रू एंड वाई में वो तंग हो जाएंगे कि 2 बाइट के बाद उनसे खाना नहीं खाया जाता। तो थर्ड थिंग, any serious attempt of the diet previously, because that's also important. Because there are two categories of patient. एक पेशेंट कहेगा कि डॉक्टर साहब मैं अपनी कोशिश से 15 किलो 20 किलो वजन मैंने 6 दफ़ा कम किया। इसका मतलब है कि रिस्ट्रिक्शन अगर उसमें ऐड कर दी जाए तो दे विल मैक्सिमली बेनिफिट फ्रॉम दीज प्रोसीजर्स। दूसरा पेशेंट है कि मैंने फाका करके देख लिया कि मैं तो जी एक ब्राउन स्लाइस ले रही हूँ, एक एग ले रही हूँ, 800 से भी कम कैलोरीज 2 महीने से ले रही हूँ, 1 किलो वजन कम नहीं होता। दिस इज सम डिफिकल्ट पेशेंट्स. If you simply add restriction to these patients, they are unlikely to benefit or will present with a weight regain soon. So selecting the right procedure, how much metabolic, how much bariatric, restriction, malabsorption, you need to know all these things. What is the metabolic profile, what are the eating practices, and this important, whether with the pre-op diet patient lose weight or they don't lose weight, this helps in making decisions. Assalamu alaikum. We welcome Dr. Mazul Hassan. You know, I will not introduce him in detail.
Please, sir.
Everyone knows Maz. Dr. Maz, thank you very much. Coming all the way from the USA for this symposium. Thank you. So, when you take a history and do the pre-operative evaluation, so you particularly ask, there are some eating disorders. Patients have compulsive eating. They cannot resist. They have to wake up in the middle of night, go to the fridge and find something to eat, and they eat a lot. And sometimes they have depression, sometimes they have schizophrenia. These are very difficult patients. If you operate on them and the post-operatively they fail to understand anything. So if you suspect any psychiatric illness, please do refer to a colleague who have an understanding of how to evaluate a bariatric patient for psychiatric disorder. So all of them are not regretted. Sometimes the psychiatric illness, they improve with the treatment and then they can be considered for surgery. But patient with major psychiatric illness should be considered for bariatric surgery after a lot of thoughtful thinking. So my mentor used to say that they don't need bariatric surgeon, they need neurosurgeon, because they have a disorder in the brain. If you only try to fix their stomach, so they will not benefit from it. Finally, you need to counsel the patient right from the beginning. Bariatric surgery is just one component. Diet and exercise are important component of any bariatric surgical procedure. They should be willing, motivated, willing to participate, and understanding that they have to continue all these. And finally, bariatric surgery is not lap chole or appendectomy. They need lifelong follow-up with the surgical team and with the dietitian. Thank you very much. If there is any question. So we move to the next talk. Dr. Adiba, please. फवाद को बुला लो।
Now I would like to invite Dr. Hameed Latif, endocrinologist from Jinnah Hospital, who will walk us through the topic medical management of obesity.
Thank you. Thank you for inviting me, Professor Farooq Rana, for two things. एक तो आपने एक बंदे थे वो चले गए तो वाहिद फिजिशियन रह गया हूँ मैं यहाँ पर, बाकी दो तो सपोर्ट के लिए बैठे हुए हैं, डॉक्टर अजहर और वो, तो शायद लगता है इसका मतलब है कि आपको थ्रेट है उनसे। दूसरा प्रोफेसर ताहिर यूनुस को मैंने 25 साल बाद देखा, इनको याद नहीं होगा, उनसे 1 साल जूनियर था और ही वॉज द फर्स्ट मैन जिन्होंने हमें कहा था जी फिजियोलॉजी के अंदर भी तुम्हें ECG आनी चाहिए, तुमने ECG इनसे पढ़ी हुई, इनको याद नहीं होगा, इसलिए कि हम दोनों डॉक्टर शनाज वाले दौर के हैं तो उससे आगे मैं नहीं बोलूँगा, सब कुछ याद हो। तो इनको याद नहीं होगा, लेकिन मुझे बहुत अच्छी तरह से याद है। थैंक यू, आपको 25 साल बाद देखा, सर नाइस टू सी यू सर। 5 से 7 मिनट के अंदर इंशाल्लाह करूँगा। सिर्फ ओनली वन थिंग जो कि आपने बड़ी ज़बरदस्त रोल की थी, और माज भाई ने मैं उसको उन्होंने बताया था कि आपके जो कि रेजिडेंट ये हैं, एक चीज़ से आपको वो कैरी फॉरवर्ड वहीं से यहाँ से राना साहब ने लेकर के, तो मेटाबॉलिक सर्जरी और पीडियाट्रिक सर्जरी के अंदर जो हम लोग एक्सपेक्ट करते हैं कि वाई मेटाबॉलिक, तो मेटाबॉलिक जो सर्जरी होगी वो ये है जो हमारे पास मरीज को नहीं लाता, मतलब रिवर्सल ऑफ ऑल द मेडिकल कंडीशन शुड बी द रूल एज कम्पेयर टू सिंपल पीडियाट्रिक सर्जरी। इसलिए गैस्ट्रिक बाईपास तो डेफिनेटली गोल्ड स्टैंडर्ड है, नेक स्लीव और बाकी सब जो स्टमक जिसमें निकालते हैं, इट इज़ लाइकली पॉसिबिलिटी कि शायद मरीज का डायबिटीज़ और हाइपरटेंशन रिवर्स ना हो, लेकिन एज कम्पेयर टू इट बाकी सारी सर्जरी जो सर ने बात की हैं, मुझे 3 ही आती थी, बाकी सर ने एनलाइटन की, और वाइवे में मेरे एक्सपेक्टेड होता है। तो वो इस इम्पॉर्टेंट बात डिफाइन करना कि व्हाट इज एक्चुअली एकेडमिकली मेटाबॉलिक सर्जरी एंड दिस, ये सर ने डिस्कस कर दिया। सिर्फ इस स्टडी को दिखाने का मकसद ये है कि दीज आर 3 एस्पेक्ट्स ऑफ ओबेसिटी, व्हाई ओबेसिटी इज इंपॉर्टेंट, दीज आर द मेटाबॉलिक जो हम लोग डील करते हैं, देन मैकेनिकल विच इज वेरी इंपॉर्टेंट एज वेल, एंड लास्टली जो सर ने राइटली सो जाने से पहले कहा था, साइक इज वेरी इंपॉर्टेंट, बिकॉज खाना एक जिद है और खाने को रोकना ही मेन क्रक्स है, इसकी वजह से हम बैठे हुए। काफ़ी लोग हैं जो नहीं खाते, आप सामने नान पराठे रख दें, और काफ़ी लोग हैं थोड़ी सी भी चीज़ हो मंचिंग के बगैर नहीं रह सकते, मामला कोई और है। दैट इज एन इम्पॉर्टेंट एस्पेक्ट वाइल यू सेलेक्ट योर पेशेंट्स। और जो गुजरांवाला की एग्जांपल सर ने राइटली सो की इस स्लाइड को आसान कर दिया है। इफ द पेशेंट इज नॉट विलिंग फॉर द फर्स्ट स्टेप, आस्क हिम कि आपको या हिम और हर क्या आपको समझ आती भी है कि आपने ओबेसिटी कम करनी है। इसलिए कि आपको पता है हमारे पास, आई एम नॉट डेरोगेटरी रिमार्क्स नहीं दूंगा, लेकिन कुछ एरियाज में ओबेसिटी इज अ हेल्थ, वो हो नहीं सकता कि वजन ज़्यादा होता है तो कहते हैं हमारी टर्मिनोलॉजी है कि हमारा वजन ज़्यादा होगा तो हम रेलिवेंट रहेंगे, एज कम्पेयर टू पतले लोगों को ज़्यादा बुली करते हैं वहाँ पर। तो इसलिए यू हैव टू एक्सेप्ट एंड फॉलो दीज 5 एस्पेक्ट्स व्हाइल यू मैनेज ओबेसिटी। और जो गदेश साहब ने मेरा आसान कर दिया, मकसद फिजियोलॉजी जो कुदरत है वो ऑप्सिनोजेनिक है, उसका मकसद ये है, इसका मतलब ये है कि सेटाइटी हार्मोन्स जो हैं, आई रियली विश कि हमारी बॉडी में सेटाइटी हार्मोन्स हैं बहुत ज़्यादा, लेकिन प्रॉब्लम क्या है, व्हेनेवर यू आर स्टार्ट लूजिंग वेट, आपका सिर्फ एक हार्मोन रहता है गर्लिन, जिसका जो पैथोफिजियोलॉजी है पीडियाट्रिक सर्जरी की बॉडी से निकालते हैं। गर्लिन आपको भूख लगाता है, तो कल को एक ऐसी स्टडीज, ऐसी हार्मोन्स भी आ जाएंगे, ऐसी भी ट्रीटमेंट आ जाएगी जो एंटी गर्लिन हार्मोन्स होंगे। इफेक्टिव कितने होंगे टाइम विल टेल। आप भी कहें लेप्टिन जिस तरह की हार्मोन है, उसकी डिटेल में मैं नहीं जाऊंगा। लेप्टिन रेजिस्टेंस वर्सेस गर्लिन हार्मोन, गर्लिन जितना कम है उतनी ही भूख कम लगेगी। ये है बेसिस पीडियाट्रिक सर्जरी की सबसे आसान की, स्लीव की। लेकिन पॉइंट ये है कि वक्त के साथ साथ आपको गर्लिन दोबारा बढ़ जाता है। दैट इज द मेन प्रॉब्लम कि मरीज सही कहते हैं आपको, डोंट जज देम कि आप तो खाना छोड़ ही नहीं सकते, खाना बिल्कुल छोड़ रहे हैं वो, लेकिन प्रॉब्लम ये है कि मेटाबॉलिज्म आपका कम हो जाएगा, बिकॉज कुदरत वो सारे हार्मोन जो 5 लिखे हुए हैं, उसकी डिटेल में नहीं जाऊंगा, उसके अगेंस्ट सिर्फ एक हार्मोन खड़ा है, गर्लिन। गर्लिन दोबारा बन जाता है और इंसान चाहकर भी भूख नहीं रोक सकता। दैट इज द मेन प्रॉब्लम, जिसकी वजह से कुदरत आपको कुदरती तौर पे यू आर प्रोन टू गेन वेट until proven otherwise. This is why this forum is very important. और आखिरी चीज before wrapping it down to the medicines name, ओबेसिटी क्लिनिक में मुसीबत यह है कि ओबेसिटी आप बड़ा आसान काम है सर्जरी के पॉइंट ऑफ व्यू से, जस्ट गो एंड गेट द नाइफ अंडर द पेशेंट। प्रॉब्लम यह है कि क्लिनिक के अंदर एक दिन में ओबेसिटी ट्रीट नहीं हो सकती, और प्रॉब्लम यह है कि अगर वो पेशेंट कंसल्टेशन हमारी छोटी मोटी दे रहा है तो हर 2 हफ्ते बाद तो देगा नहीं, 2 हफ्ते में फर्क भी नहीं पड़ेगा। तो प्रॉब्लम ये है कि दिस इज अ मल्टीडिसिप्लिनरी अप्रोच, यू हैव टू इन्वॉल्व एवरीबॉडी, और उसके लिए एक आइडियल सिस्टम चाहिए कि ओबेसिटी क्लिनिक हो जिसके अंदर अंडर वन रूफ सब लोग बैठे हों। आपको असेस करना चाहिए कौन से इंसान किस जगह पर जाएगा, वन शू डजंट फिट ऑल। सर ने इसको डिस्कस कर चुके हैं राणा साहब। ये है इंपॉर्टेंस ऑफ द रिडक्शन इन द परसेंटेज ऑफ वेट, इसके बाद कौन कौन सी बीमारियां सिरे से खत्म हो जाती हैं। स्टार्टिंग फ्रॉम लेफ्ट टू राइट यू हैव सिर्फ 5%, 100 का बंदा 95 का हो गया तो हाइपरटेंशन की दवाई खत्म ना भी सही आधी जरूर हो जाएंगी, टू मोर देन 15% रिवर्सल ऑफ डायबिटीज। इट्स अ ह्यूज बेनिफिट। इससे कि डायबिटीज की दवाइयां भी थोड़ी बहुत महंगी, बेशक उतनी नहीं है जितनी पीडियाट्रिक सर्जरी की कॉस्ट है, कि लॉन्ग टर्म में तो चलेगी ना। मल्टीप्लाई करते हैं 25, अभी जो आ रहा है, जो आगे वाले आ रहे हैं 2.5 लाख का है, मल्टीप्लाई पे 12 तो तकरीबन 3 लाख रुपए, मतलब तकरीबन 2 करोड़ से तो ऊपर एक साल के उसे खर्चा हो जाएगा, वो रिमिशन हो जाएगा जस्ट बाय रिडक्शन इन 15% ऑफ वेट। और ये एक चीज बोरिंग चीज आपको हमेशा नजर आएगी टिल यू आर डॉक्टर कि ये नहीं हो सकता कि यू हैव टू फॉलो द रूट। और नीचे से ऊपर अगर आप जाएं जो प्लसेस हैं वो हर एक बंदे को इम्पोर्टेंट है टिल पीडियाट्रिक सर्जरी, जो कि अभी राणा साहब ने बताया भी। और बाकी BMI 30 से पे हो गया। जब मैं स्टूडेंट था उस जमाने में हमारा कट ऑफ था 35, अब 30 हो गया बिकॉज एशियंस के कोमॉर्बिडिटीज जल्दी शुरू होती हैं। और 27.5 BMI विद कोमॉर्बिडिटीज merits you to have a pediatric surgery theoretically, ethically, legally and medically। पहले नहीं था। इम्पोर्टेंट बात कि आपको कॉन्सेप्ट क्लियर होना चाहिए। इसलिए ऑफर देम बिकॉज पाकिस्तान में अल्हम्दुलिल्लाह अब स्टार्ट हो रही है। मेरे होते इट वाज वेरी अर्ली, इट वाज वे बैड। 2013 में पास आउट हुआ था, उस जमाने में पीडियाट्रिक सर्जरी के स्पेलिंग मुझे भी नहीं आते थे। पहली दफ़ा फारूक भाई ने हमने उनको बुलाया था, सर को याद नहीं होगा, हमने DMC में, तो सर ने बताया था कि हाउ टू डू इट। हमने सिर्फ रट्टा मारा था उस वक्त, वाइवे में पूछेंगे आपसे। एक MCQ होता था, विच ऑफ द फॉलोइंग ऑप्शंस इज अ टोटल आंसर टू डायबिटीज रिमिशन। उस वक्त सिर्फ आंसर वही होता था पीडियाट्रिक सर्जरी, अभी भी शायद वही है। दीज आर द रिस्क फैक्टर्स, जिसकी वजह से अगला स्लाइड है। ये रिस्क फैक्टर्स होंगे, यू हैव टू टेक द पेशेंट सीरियसली। और आप हो नहीं सकता कि रिस्क फैक्टर आपके हर मरीज में ना हो जो HLH में आ रहा है। दिस इज द लास्ट स्लाइड जिसके अंदर आपको वावेला मच जाएगा कौन सी दवाई में दे क्यों रहे हैं, हर बंदा ओज़ेम्पिक दे क्यों रहा है। तो बाकी ओज़ेम्पिक इज द आंसर। नंबर 1 तो ये है कि ये जो सर्कल है इट्स इंपॉर्टेंट। ओज़ेम्पिक से पहले ये वाला एक्सरसाइज जरूर कीजिएगा। पेशेंट शुड बी काउंसिल्ड रिगार्डिंग नेचुरल कोर्स ऑफ द डिसऑर्डर जस्ट टू मेंटेन वेट। बात बिल्कुल सही है, जितनी मर्जी एक्सरसाइज आप कर लें, आउटसाइड जो सेलिब्रिटीज करते हैं फॉर द मूवीज, उसकी बात नहीं कर रहा। आपका वेट मेंटेन जरूर रह सकता है, कम नहीं होगा, बॉडी शेप में आ सकती है, कम नहीं होगा अगर ये एक्सरसाइज कर लेंगे। तो ये मैं सिर्फ लेफ्ट वाला टेबल पढ़ूंगा, सिर्फ राइट वाला डायबिटीज का वो आपके लिए है नहीं, सिर्फ राइट में दवाइयाँ थोड़ी ज़्यादा हैं, गलत इन्फॉर्मेशन चलेगा। जो लेफ्ट वाला डब्बा है ना, ये 3 दवाइयाँ हैं जो कि अप्रूव्ड हैं। और पाकिस्तान में एक दवाई जो है वो अगले महीने मिलना शुरू हो जाएगी। उसके बाद शायद मैं दोबारा आकर आपसे मुकाबला कर सकूँ सर्जन्स के साथ, जैसे कि वो 21% वेट लॉस कर देता है। कहा तो ये गया है, प्रॉब्लम सिर्फ वहाँ पर भी कॉस्ट आती है। और हर दवाई इंक्लूडिंग ट्रेज़ोपेटाइड, जब ये स्लाइड आई थी उस जमाने में ट्रेज़ोपेटाइड, हम लोगों का असल में बेसिकली वेट लॉस के अलावा 2-3 और बोरिंग चीज़ें होती हैं जो मैं बतानी होती हैं। द पेशेंट हैज़ बेनिफिटेड विद एथेरोस्क्लेरोटिक कार्डियोवास्कुलर डिजीज। पेशेंट को नॉन फेटल MI नहीं होगा वजन कम करने से। ये दवाई पेशेंट के एक्चुअली हार्ट अटैक को बचाएगी, या अगर आपको इस्केमिक हार्ट डिजीज हो चुकी है तो उसको रेकर नहीं करवाएगी। और हर दवाई मेडिसिन के अंदर कार्डियोवास्कुलर सेफ्टी से गुजरने की बात जरूरी है। इसलिए जो राइट साइड वाली सारी दवाइयाँ हैं सिर्फ वो हैं कि हमारे असल में बच्चों के लिए हैं। जो सवाल का जवाब है, जस्ट एनुमरेट द मेडिसिन्स व्हिच आर आउट एंड आउट यूज फॉर ओबेसिटी। तो ये वो सारी दवाइयाँ 1, 2, 3, 4, 5, 6 ये दवाइयाँ अप्रूव्ड हैं। इसके अलावा बाकी सारी दवाइयाँ इंक्लूडिंग हार्मोन्स कुछ होते हैं, आपको शायद उसके टाकरा नहीं होता होगा, लेकिन फिजिशियंस को जरूर टाकरा होता है कि हमारे HCG और टेस्टोस्टेरोन भी लोग लगाते हैं just to get into the shape और weight loss के लिए, which is totally unethical। तो ट्रेज़ोपेटाइड is there to stay जो नई दवाई है, उसके 2 वजूहात हैं। एक तो वजह ये है कि अमेरिका ने बनाई है और अमेरिका ओज़ेम्पिक के अगेंस्ट जा रहा है, बिकॉज ओज़ेम्पिक अमेरिका की दवाई नहीं है। जो आपके सारे डाटा हैं वो सारे सही भी नहीं है, उसको आप क्रिटिकली एवेल्युएट किया करें। क्रिटिकल अप्रेजल इसलिए इंपॉर्टेंट है। तो कोई भी दवाई मुकम्मल तौर पर हर बंदे के लिए नहीं है, चाहे वो ओज़ेम्पिक हो चाहे वो मंजारो हो, और ये दोनों डोज पे डिपेंड करता है। सिर्फ मकसद इस स्लाइड का ये है कि हर बंदा हर एक के लिए नहीं है। यू जस्ट हैव टू नो वन थिंग, व्हेन नॉट टू गिव। इसलिए कि यहाँ पर मरीज आए हैं जो कि सडन डेथ के साथ रिपोर्ट हुए हैं, ऐसे मरीज आए हैं जो ब्लाइंड हुए हैं, और जो गॉल स्टोन्स हैं इसकी फ्रीक्वेंसी बढ़ जाती है। तो ये सारी चीज़ें कॉन्ट्राइंडिकेशन को रूल आउट करने के बाद प्लीज़ अपने मरीज को दिया करें। इसलिए स्पेशली मैसेज आपको दे रहा हूँ कि जिस तरह हृदय साहब ने कहा था, वेडिंग का पैकेज भी पिछले साल आ गया था। अभी उन्होंने नोवो वालों ने इसको वो किया था कि प्लीज़ इसको हम जो अल्टरनेटिव मेडिसिन प्रैक्टिस करें वो लोग नहीं दे सकते। लेकिन पाकिस्तान में आपको पता है अनफॉर्चुनेटली हर बंदा टिकटॉकर, हर बंदा इसको बेच रहा है। तो मकसद सर्विस राइट का ये है कि व्हेन नॉट टू गिव। इसकी कॉन्ट्राइंडिकेशन के अंदर 2 एब्सोल्यूट कॉन्ट्राइंडिकेशन है। एक पैनक्रेटाइटिस, चाहे गॉल स्टोन पैनक्रेटाइटिस भी हुआ हो, डोंट ट्राई टू गिव इट, इसलिए कि अगर खुदा ना खास्ता दोबारा हो गया वो आपकी बात नहीं मानेगा। हालांकि किताबों में पैनक्रेटाइटिस इर्रिस्पेक्टिव ऑफ कॉज लिखा हुआ है। तो पैनक्रेटाइटिस अगर किसी को हुआ है, शक भी है आपको, जैसे पैनक्रेटाइटिस अगर पहले हुआ है, आपको सिर्फ हिस्ट्री से पता चलेगा ना किसको हो गया है। तो देयर इज नो साइन। और ये भी इंटरेस्टिंगली ऐसा कोई रिकमेंडेशन नहीं है कि एमाइलेज लैपेज कराते रहे मरीज का। देयर इज नो गाइडलाइन। लेकिन प्रॉब्लम ये है कि अगर ये दूसरे में मिडलरी थायराइड कैंसर एक खास किस्म की मैन होता है तो वो रूल आउट करने का प्रॉब्लम ये है कि वो भी हम यूजुअली रूल आउट नहीं करते, लेकिन आपको इतना जरूर पता होता है कि अगर फैमिली हिस्ट्री ऑफ एनी थायराइड डिसऑर्डर हो तो एटलीस्ट आप एक ओपिनियन जरूर ले लिया करें स्पेशलिस्ट से, ताकि पता हो कि किसको नहीं देना। आखिरी चीज जो अक्सर औकात पहले लोगों ने नहीं किया, वो जो अभी तक सिर्फ सेमाग्लूटाइड के साथ प्रूवन है, बाकियों के साथ नहीं है, इंक्लूडिंग लैराग्लूटाइड, प्रोलिफरेटिव रेटिनोपैथी अगर आपको है, बैकग्राउंड नहीं प्रोलिफरेटिव, तो आप प्लीज डोंट इनिशिएट GLP-1, वो वर्स कर देंगे उसको, द पेशेंट विल एंड अप बीइंग ब्लाइंड। इसलिए ये इतनी ज्यादा इंपॉर्टेंट कॉन्ट्राइंडिकेशन है कि आप उस मरीज को बताएंगे तो जिस तरह राणा साहब ने कहा था कि उसने काउंसिल करने के बाद गुजरा वाला बंदा भाग गया था, अक्सर औकात लोग नहीं आएंगे। अभी तक एक केस है, अदनान शाह यहाँ पे है नहीं, शायद इमरान को बताओ कि अक्सर औकात एक बंदे ने अभी भी मेरे खिलाफ यहाँ पे बड़ा शिकायत की हुई है, बंदी बड़ी मुश्किल है, उसकी वालदा 0.5 पे ठीक थी, 1 मिलीग्राम दिया, वॉमिटिंग शुरू हो गई, उसने गालियाँ, उसने तो थ्रेट करना शुरू कर दिया, पता नहीं अभी तक लंबे चल रहे हैं केस, और उसको बचाव जाके थक गए लेकिन नहीं मान रहे। प्रॉब्लम ये है कि एक चीज व्हेन टू गिव एंड व्हेन नॉट टू एस्केलेट, ये दोनों चीजों को आपने चीज को मुंह से खाते रखना है। दिस इज वेरी इंपॉर्टेंट। दिस इज व्हाट हैपेंस, जिसकी वजह से आज वाला सिंपोजियम है। वंस यू स्टॉप टेकिंग GLP-1 योर वेट, ये बहुत इंपॉर्टेंट, और ये आपको हर जगह मिलेगा। सर 6 महीने हो गए, बंद ना कर दें। ऑब्वियसली 2 वजूहात से लोग बंद करते हैं, शॉर्ट टर्म में तो साइड इफेक्ट, लॉन्ग टर्म में जितना मर्जी करते हैं। पेशेंट वाइट कॉलर होते हैं, वो शर्म से बोल नहीं रहे होते। मैं इसकी बात नहीं कर रहा कि पाकिस्तानी वर्जन भी अब आ गया, बहुत सस्ता हो गया, हालांकि वो बायो सिमिलर है, तब भी इफेक्ट तो कर रहा है, लेकिन मरीज कहता है आपको 6 महीने बाद से बस हो गई। 25 भी मल्टीप्लाई पे ईयरली मंथली कर लें। मंजारों की बात तो भी मैं कर नहीं रहा इसलिए कि पाकिस्तान में अवेलेबल नहीं है, तब भी काफ़ी लोग ना हेल्थ प्रायोरिटी नहीं है, वो कहते हैं सर बस हो गई। जब आप बंद करेंगे तो यू हैव टू फॉलो दैट फुल regime. Despite following the full regime, the patient is definitely going to gain weight because उसका पहला मल्टीपल फैक्टर्स की वजह से पहले ही वो obese था। तो इसलिए प्लीज उसको काउंसिल जरूर कीजिएगा कि स्टार्ट करने से पहले ये समझ लीजिएगा ये फ्रेम नहीं हुआ होगा कि ज़ेम्पिक बंद करने के बाद ये कसम से मैं बता सकता हूँ वजन कम बढ़ेगा नहीं, ऐसा नहीं हो सकता। तो बैरिएट्रिक सर्जरी के अंदर भी शायद बढ़ जाता है, वो सर ज़्यादा एनलाइटन करेंगे, लॉन्ग टर्म में बढ़ेगा लेकिन शॉर्ट टर्म में बढ़ जाएगा। तो प्लीज ये जरूर काउंसिल कीजिएगा। दिस इज द इफेक्टिविटी ऑफ मल्टीपल GLP-1s which are currently FDA approved। सबसे ज़्यादा होल्ड्स ट्रू एंड वो कट थ्रोट किस्म की जीत आ गई है सेमाग्लूटाइड की, वो सॉरी ट्रिज़ेपिटाइड की, बिकॉज वो GLP एगोनिस्ट है, ग्लूकागॉन एगोनिस्ट भी है। 21% फॉलो बाय सेमाग्लूटाइड, बाकी सब अनफॉर्चुनेटली इन दोनों दवाइयों के बाद अब ना के बराबर लिखी जा रही हैं। तो ये बड़ी इंपॉर्टेंट बात है कि 21% इसने रिकमेंडेड इसकी वेट लॉस है, प्रोवाइडेड कि मरीज कितना अरसा ले, ये इंपॉर्टेंट है, एक शॉट के बाद नहीं होगा। और ये डोज डिपेंडेंट है, 2.5 से लेकर 15 मिलीग्राम तक है ट्रिज़ेपिटाइड। और ये जहन में रखिएगा 2.5 की जो कॉस्ट है उसको 5 टाइम्स मल्टीप्लाई करेंगे तो 15 मिलीग्राम तक जाएगा। मैं बार बार इसलिए पाकिस्तान में कह रहा हूँ कॉस्ट डज मेक अ डिफरेंस। जो बाहर के लोगों में कवरेज आती होगी वो गालिबन मुझे ताहिर भाई या बाकी लोग कहेंगे, मेरा नहीं, मुझे अभी तक आइडिया नहीं है कि चेस्ट फॉर ओबेसिटी मंजियारो अप्रूव्ड है अमेरिका में कि नहीं। ओज़ेम्पिक तो है लेकिन ओज़ेम्पिक को देते हैं लेकिन विगोवी नहीं देते। मेरे 2 कैनेडियन पेशेंट जो आते हैं वो ये कहते हैं, और अमेरिकन इजी ओज़ेम्पिक सर उस वक्त देंगे जब डायबिटीज़ के लिए लिखेंगे, जस्ट फॉर मेयर वेट लॉस अभी भी वो नहीं दे रहे। लेकिन ये मेरी करंट नॉलेज नहीं है, शायद मैं गलत हूँ। दिस इज द लास्ट स्लाइड। ओबेसिटी जैसे सर ने कहा था कि एपिडेमिक है ही, और प्लीज इंटीग्रेटेड कंटिन्यूअस एंड बायलैटरल एफर्ट्स। ये नहीं हो सकता कि ज़बरदस्ती हम मरीज को रोड क्रॉस कराएंगे जब तक वो वजन कम नहीं करना चाहेगा ज़बरदस्ती ना। अब वो आएगा आपके लिए हेडेक के लिए, वजन ना कम कर लें आप, चलें ये भी साथ ले लें, ये ना कीजिएगा प्लीज। इट डजंट हेल्प, इट डजंट हेल्प एट ऑल। देयर इज नो ब्लैंकेट ट्रीटमेंट, हर बंदा एक दवाई के लिए नहीं बना हुआ। एंड लास्टली डू एक्सरसाइज। ये एक्सरसाइज वो वर्जिश वाला एक्सरसाइज नहीं है, प्रैक्टिस वाला एक्सरसाइज है। डू एक्सरसाइज, व्हाट नॉट टू डू व्हाइल मैनेजिंग वेस्ट। जज़ाकल्लाह।
welcome Professor Farooq Afzal, who is one of the pioneer bariatric surgeon in Lahore and very renowned surgeon, and currently is working as a principal of Hameed Latif Medical College. Thank you very much for joining us.
Now I would like to invite Dr. Tahir Yunus, who is a renowned board certified bariatric surgeon, who will speak on physiology and evaluation of patients with weight regain after bariatric surgery. An important reminder that post-op follow-up and re-evaluation matter just as much as the initial success.
Bismillah. Can I get some water, please? Bismillah ar-Rahman ar-Rahim. First of all, thank you very much, Professor Farooq Sahab, for this nice invitation, and thank you all for inviting me over here. So we'll talk a little bit about the physiology of obesity and weight regain in perspective of the physiology. So we've had a number of talks, mashallah, and excellent talks which have highlighted a lot of the aspects of physiology. The objective today for my talk, thank you so much, is to talk about why does regain happen and how do you approach these patients considering their physiological background of weight regain. Because if you sort of understand why they're having the weight regain, it makes it easier for you to choose how to address the problem. Because there are many reasons for having weight regain. So you have to sort of understand the problem so that you can give the treatment. Just like Professor Fawad Sahab just said, he highlighted how there's no blanket treatment for every patient. You have to sort of identify which patient gets which treatment. So I'm going to just try to simplify that thought process for you so it makes it easy for you to understand. And if anybody has any questions along the way, feel free to ask, because it opens up a little bit of discussion. So we're going to talk a little bit about the understanding obesity, the physiological mechanisms, and how regain happens and what should we do. So simply, there are two pathways of managing our weight. There is the metabolic pathway, which has homeostatic mechanisms that are managed through the hypothalamus. So constantly our brain is measuring how much energy we have stored in the form of fat. It's constantly measuring it. And just like you have your air conditioner that is fixed at a certain temperature and it's measuring the room temperature and controlling the amount of cooling, similarly our brain is measuring the amount of energy that is stored in our body and managing it. And that is happening within the hypothalamus through various pathways. The fat is the largest endocrine organ of our body. It's not just a dormant tissue. Fat is a very endocrinologically active organ, and it's constantly producing various hormones. These hormones are affecting a variety of different functions, not just weight. They're even affecting, like PCOS is mainly a disorder of the hormones that are coming out from fats, and it's affecting the lives of many ladies, and in many ways, and even in men. Those fats are producing a variety of hormones that are even affecting their reproductive functions and other functions. So fat is not just a dormant tissue, it's an endocrinologically active tissue. And so the fats are producing hormones that are going to the system. The hypothalamus has various ways of measuring it. And so what I'm just trying to say is that there is a circuit that exists within our body that is constantly measuring and controlling. When this disturbs, then you have increased obesity. Like for instance, none of us does any effort to control our blood pressure. For instance, if in the month of July we're fasting and we don't eat for 16 hours, and we don't drink for 16 hours, and we're working in the heat and we're sweating, we get dehydrated, our blood pressure is maintained. And after Seri, when we've had like 2 liters of water, our blood pressure is still maintained. Despite maximum hydration and dehydration, we are within a range. So our body accommodates those variabilities and maintains us. And this is called homeostasis. And the same for our temperature. Whether we're in summer or in winter, we're maintained. And the same goes for weight. It's supposed to be maintained. But when mechanisms, the homeostatic mechanisms get disturbed, then weight increases. Just like homeostatic mechanisms get disturbed, blood pressure goes up, temperature goes up. It's the same concept. There are a variety of different causes that we can identify, but the majority we cannot identify what are the reasons why these mechanisms get disturbed. For instance, there are some polygenic traits, so multiple different genetic changes that we have identified that could be associated with obesity. And so you say that there's a family inheritance of obesity in this family. Sometimes it's epigenetics. So what is epigenetics? Epigenetics are those controllers that are opening and closing genes that get affected by the environment. So environment can also affect the genetic traits. And then in our environment, we have a variety of different changes that have happened. For instance, the amount of radiation that exists in our environment is much higher than what it was before. The amount of processed foods that exist in our environment are much more than what we had before. So these all things can affect those homeostatic mechanisms that we mentioned. So our body tends to resist weight loss. It defends the weight. It defends it in a good way, that it tries to maintain the weight within a range. But the mechanisms to prevent weight loss are stronger than the mechanisms to prevent weight gain. The mechanisms to prevent weight gain are weaker. And so it's easier for us to gain weight without controlling the weight. And it's very difficult for us to lose the weight. And unfortunately, what we've learned over time is that those mechanisms then get adjusted at a newer set point. So let's say over the years, somebody, for some reason, had a trauma, had an accident, got exposed to multiple medications, and their weight goes up because the body is unable to prevent the weight gain and gets stable at a new level. It's very difficult for the body to bring it down to the previous level, but it'll maintain it at the new level. And then another event will happen in life, and it will then go up to another level. Now, these things do not change after bariatric surgery. So, for instance, somebody has bariatric surgery. Bariatric surgery tends to bring that new set point down, and you re-establish yourself at a new set point. But what if 5 years down the road, that bariatric patient has an accident and has to have is bedridden for a while, takes multiple medications, or gets steroids or whatever, that causes the new set point to develop. So the weight regain, even after bariatric surgery, can happen for the same reasons that weight regain occurs before bariatric surgery. So it's not specific that the bariatric surgery failed, but it's because our homeostatic mechanisms are prone to weight gain more than they are to weight loss. So we have a different variety of different hormones and mechanisms. Now, so what are the causes of weight gain? We classify them into 4 areas. One is behavioral, the second is psychological, the third is anatomic, and the fourth is metabolic. So how do you differentiate? What's the difference between all of these? I'm going to even simplify it further than this. I'm going to make it only two. One is metabolic pathway and one is hedonic pathway. So like for instance, I'll give you an example. A lion is given some food. He eats to the full and goes to sleep. Then even if you bring more food in front of that lion, he will not get up to eat because he's metabolically satiety. He's full. He will not get up to eat because there's no added flavor to that meat. But when you make it tandoori and you add flavor, or you make it a korma or a karai and you add flavor and you bring naans, you add flavor, now it's not metabolic hunger.
Everybody's smiling because
So just by naming those things, you've already brought in your mind an image, a flavor, a smell, a sound, and the emotions that were associated the last time you ate these things, the happiness. So that is what we call the reward pathway or the hedonic pathway. So hedonic pathway is above the metabolic pathway. It doesn't get affected by the hunger and satiety that exists around the metabolic pathway. And so the first two, which is behavioral and psychological, revolve around the hedonic pathway. What's the difference? Behavioral, we say poor dietary habits. We call it poor. That person doesn't call it poor at all. He says, I'm enjoying food. And it's actually quite expensive. So what's the difference? The difference is that that food is giving him increased happiness. So they're at this level, neutral level, and they want to get more happy with the food. What about psychological depression and binge eating? That person is a sad person, and the sadness gets elevated by food, so he wants to become normal. So in both cases, you're increasing the level of happiness through reward mechanisms, and so you're going through the hedonic pathway, which is regardless of what the body fat is telling the brain. So it's not about how much fat is signaling the brain about the energy stores. It's about the happiness that is associated with the food. Whether you're a sad person and you want to become happy, or you're a happy person and you want to become more happier. Okay? And so these two are both hedonic pathways. Then we come down to the metabolic and anatomical. That is where the medications and bariatric surgeries interact. Okay? So when we do bariatric surgery, we are addressing the metabolic pathway. We're addressing hunger, satiety, that's not related to behavior and depression. We're addressing the biological hunger. So some patients will tell you that we eat to our full, and immediately 2 hours after we've eaten, we feel hungry. We feel very hungry. And if we don't eat, our blood sugar goes down. And we feel very weak and we start getting blackouts. So this is the metabolic pathway. Some patients will tell you that I eat and a small meal and then I don't eat all day. And I eat at night. And they're really not eating much, very little, but their weight does not move. They're probably eating only 500 calories in the whole day and their weight does not move. Again, this is the metabolic pathway. But what's the difference? One has hunger and one does not have hunger. But the brain is preventing the weight loss in both cases. Why? In one case, the brain is increasing the hunger hormone, and in the other case, the brain is reducing thermogenesis, which means energy loss. So the brain is preventing thermogenesis to preserve energy, to protect the weight in one mechanism, and in the other mechanism, it's not preventing thermogenesis, but it's increasing calorie intake by changing behaviors, forcing the person to eat, by increasing hunger. Both of these are metabolic pathways. So when you do bariatric surgery, both get affected. Number one, your hunger hormone goes down, and number two, your thermogenesis increases. But when you use medications, the ones that were mentioned before, it only reduces hunger. So your hunger hormone is reduced by medications, but you cannot increase thermogenesis. So bariatric surgery does two things: reduce hunger hormone, increase thermogenesis. Medications only do one thing: reduce hunger. And this is regardless of the hedonic aspect, which is the happiness that is associated with eating, or the reduction of depression that is associated with eating. We're not talking about that right now. Now, we come down to, so how do we evaluate a patient? What's the mechanism to evaluate the patient? So you start talking to the patient, you ask him, so if you eat food, how much do you eat? First of all, portion size. And after you eat, how long do you feel full? Satiety time. And then when do you get hungry again? And when you eat, what is the food that you eat? Dietary choices. Do you eat because of hunger or just because you want to feel good? Depression versus happiness, hedonic eating. So these are things that you just get from the history. Now you're not able to decide is that if this patient will benefit from metabolic treatment or does he just need psychological treatment? Because if it's all hedonic, then you will not benefit just by doing bariatric surgery or adding medications. You do need cognitive behavioral therapy. The question is that will this patient benefit further or not? So you give a trial of GLP-1 medications if it's allowed, if it's not contraindicated. So you give a trial. If the patient on the trial of GLP-1 medication says, my hunger is suppressed and I'm feeling better, that means that now if we redo bariatric surgery, this patient will benefit. But if they're not benefiting from any GLP-1s, adding further bariatric surgery may not benefit this patient at all. So then you have to sort of delineate, do I just need psychological therapy or do I need to do further bariatric surgery by giving a trial of GLP-1s? So you give a trial of GLP-1s and then at the same time you check other things. Like for instance, in the previous slide, I told you that there could be an anatomical reason. Now, in the past, when bariatric surgeries were still being learned and there were a variety of different surgeons doing bariatric surgeries, there were a variety of different problems. The most common was a large pouch size. So patients would come in, they would have weight loss with gastric bypass surgery and then have regain. And the majority of times when we would reassess these patients, it was because their pouch size that was created was very large in the first bariatric surgery. Everybody will have honeymoon weight loss even with a large pouch. Everybody. But everybody who has a large pouch will most likely have regain after 3 to 5 years. And it is at 5 years that they come back with weight regain and the problems because of the large gastric pouch. It's not in the beginning. Everybody has a happy honeymoon phase. Now, that is the cases when we used to then resize the pouch and try to fix it, but they will never lose weight. You will never lose weight. Because if you have a large pouch size, you have initial weight loss, you will have then weight regain. Even if you resize the pouch, the body is now set a new set point. It will not come down. Then we used to start adding more restriction by putting a band on the pouch or making it tight, doing endoscopic suturing of the anastomosis or even stapling the anastomosis, making it tight to add restriction. All of them, 1 year results. They would lose, regain, because the body and mind is set new at a new set point. The physiology is set at a new place. What is the solution to these patients then? When you have a wrong anatomy, whether it's a large sleeve or it's a large pouch, and you lose and then you regain, there is some option of doing obesity management medications by controlling their metabolism again by the set point, by giving them medications. But if you look for redo bariatric surgery in these cases, it's very difficult. There are now new options of bariatric surgery that are looking into the same metabolic aspect of medications. For instance, when we do the distal bypasses that Dr. Farooq had showed you, where we bring the stimulation of food to the distal gut, the last 300 centimeters, just stimulating the ileum with the food. So early stimulation of ileum does give that same metabolic aspect of medications. Without the medication, it's autologous incretin production. So you get your own body to increase the incretin levels to reduce that hunger hormone, increase the satiety time. A lot of what I'm saying sounds like crazy, doesn't it? But this is, we'll just summarize it over here, is that when you have these kind of patients, you need to have a multidisciplinary approach where a surgeon, dietitian, and psychologist work together. They look at behavioral therapy, lifestyle modifications. They give a trial of pharmacotherapy. If that works out, that's good enough. You don't need to jump to redo bariatric surgery. If you still need to go to redo bariatric surgery, then there are a variety of different endoscopic and surgical options that are actually further developing as we speak, especially with the advent of magnets in the use of different surgeries. So that could be an option as well in the future. So obesity is a multifactorial disease with neurohormonal regulation. Weight regain after bariatric surgery requires structured evaluation and a personalized team-based approach. Thank you very much.
Thank you so much, Dr. Tai. Now let's turn our attention to nutrition, a cornerstone of long-term success. Please welcome Dr. Samrat Ali, who will present on nutritional management after bariatric surgery.
So weight regain is a serious challenge, and many patients present with weight regain after bariatric surgery. So their evaluation should be scientific, evidence-based, and at the same whether we can offer them a renal procedure, they need to manage medically, they has to be learned and practiced. If there's any question, you can reference to the of Dr.
Multiple mechanisms, it increases the body's ability to spend energy rather than preserve energy. So there's the bile acid mechanism, there's the microbiome, there's multiple
stomach bypass surgery or any kind of bariatric surgery, we address the ghrelin because ghrelin is most commonly secreted by the fundus of the stomach. Ghrelin is decreased with different studies also. How can we manage this ghrelin after bariatric surgery?
So ghrelin is one of the hormones. We also have leptin. We also GLP. There are about 20 different hormones that changes after bariatric surgery. Ghrelin is easy for them to identify, but it's not yet pharmacological grade. It's not been successful. GLP-1s have actually, different studies after bariatric surgery, been proven to be the but there's also the leptin. For instance, when we gain weight, the fat produces leptin, which helps reduce weight. Leptin. So leptin, we know that as people lose weight, their ability to produce leptin decreases as well. And leptin is an important hormone to reduce hunger. So if you're not producing leptin, your hunger will go up. So it's not just ghrelin, it's a hormone. So one hormone is now picked up GLP-1s, now we're adding GLP-1s to GLP, but we have a lot more coming in years that that's now phase 3. As we know, we reduce weight or increase muscle, and it's going to be 26 years. So it's a frontier that's still expanding very rapidly.
I just want to add that it is so not only patients, it's not only also diseases, but there is also lifetime diseases. So normally if you measure the lifetime levels, right, and you think with the obesity they should have low levels, but in bariatric patients they have high levels. So maybe ideally the lactation should basically be before weight, but it is elevated. So this explains the resistance they have for the lifetime.
Assalamualaikum everyone. I hope everyone is doing great. I am Samra Tariq and I am practicing as a dietitian at Hameed Latif Hospital since 2022. First of all, I would like to extend my gratitude towards Dr. Farooq Rana and Dr. Javed Kartezi for giving me this opportunity to speak in front of so many respectable guests right now. So let's start my presentation. Today I am going to discuss how nutrition is important in managing the bariatric surgery patients. So first of all, when a patient visits a dietitian, we mentally prepare a patient like we are going to proceed further towards surgery. For preoperative management, we discuss patients regarding different foods. कि पेशेंट कौन सी फूड्स जो है वो डेली बेसिस पे यूज़ कर रहा है, कंप्लीट उसकी डाइटरी हिस्ट्री ली जाती है, फूड फ्रीक्वेंसी क्वेश्चनियर्स होते हैं. आफ्टर evaluating the patient, we move forward about BMI, पेशेंट का बॉडी मैस इंडेक्स कितना है, एज ऑलरेडी डिस्कस बाय डॉक्टर फारूक राना ऑन डिटेल कि पेशेंट जो है अगर उसका BMI 30 अबव है, देन फर्दर हम उसको मैनेज करते हैं डाइट के साथ. डाइटरी मैनेजमेंट जो है वो प्रोलॉन्ग नहीं करती. समटाइम पेशेंट लूज वेट फॉर अ सर्टेन टाइम ऑफ पीरियड, आफ्टरवर्ड्स पेशेंट रीगेन इट ड्यू टू लाइफस्टाइल, ड्यू टू हार्मोन्स, ड्यू टू जीन्स एंड डिफरेंट अदर इश्यूज. सो वी मूव फॉरवर्ड कि पेशेंट का अगर BMI हमारे पास जो है वो 30 अबव है, ओबीस ग्रेड 1 पे फॉल कर रहा है, देन 35 to 40 पे है, ग्रेड 2 ओबेसिटी है या ग्रेड 3 ओबेसिटी है. एंड विद ऑल दीज BMI पेशेंट जो है वो डिफरेंट डाइट पैटर्न्स फॉलो कर चुका हुआ है, फैट डाइट्स ले चुका हुआ है, एंड स्टिल पेशेंट वेट लॉस नहीं कर पा रहा. देन वी काउंसल द पेशेंट फॉर ए मंथ, जिसमें हम पेशेंट की डाइटरी हैबिट्स को थोड़ा सा चेंज करते हैं, पेशेंट को सर्जरी के लिए प्रिपेयर कराते हैं, जिसमें हम लो एनर्जी डाइट को रिकमेंड करते हैं, लो शुगर्स, लो कार्ब्स एंड लो फैट डाइट फॉर ए मंथ, जिसमें पेशेंट मेंटली प्रिपेयर हो जाता है फॉर ए सर्जरी. लेटर ऑन आफ्टर सर्जरी हम पेशेंट की मैनेजमेंट जो है वो फेजेस वाइज करते हैं, फ्रॉम फेज 1 टिल फेज 5. डिफरेंट पेशेंट्स की टॉलरेंस डिफरेंट होती है. समटाइम पेशेंट टॉलरेट फूड वेल. ऑन फर्स्ट POD पेशेंट को स्टार्ट करते हैं विद अ सिप ऑफ वाटर एज पर पेशेंट टॉलरेंस, हम उसको ग्रेजुअली इंक्रीज कराते हैं. लेटर ऑन टिल सेकेंड POD हम उसकी क्वांटिटी को मजीद इंक्रीज कराते हैं. The quantity totally depends upon the patient surgical procedure. अगर उसका जो पाउच है उसकी कैपेसिटी कम है तो हम उसको जो फूड दे रहे हैं लिक्विड डाइट, क्लियर लिक्विड डाइट, उसकी हम क्वांटिटी कम रखते हैं. लेटर ऑन मूविंग टुवर्ड द सेकेंड फेज विच इज फुल लिक्विड डाइट. फुल लिक्विड डाइट जो है हम नेक्स्ट 3rd and 4th डे उस पेशेंट की चलाते हैं. इफ पेशेंट इज टॉलरेटिंग वेल लिक्विड डाइट, देन फर्दर उसको मजीद हम प्रोग्रेस कराते हैं. लिक्विड डाइट में हमारे पास ऑप्शंस में प्रोटीन रिच डाइट की आती हैं, प्रोटीन पाउडर्स हैं, यखनी है. उसके अलावा हम पेशेंट्स को डिफरेंट डाइल्यूटेड फॉर्म में जूस दे सकते हैं, बट मेक श्योर करना है कि जो लिक्विड की कंसिस्टेंसी है इट शुड बी लाइक मिल्क कंसिस्टेंसी. लेटर ऑन इफ पेशेंट टॉलरेंस इम्प्रूव्स इन 3rd and 4th डे, हम फर्दर मूव करते हैं टुवर्ड्स फेज 3rd विच इज कम्प्लीटली प्यूरिड डाइट. दिस डाइट इज लाइक बेबी फूड कंसिस्टेंसी, जिसमें हम पेशेंट्स को हाई प्रोटीन पे फोकस कराते हैं, क्योंकि सर्जरी के बाद पेशेंट की प्रोटीन नीड इंक्रीज करती है. एंड देन हम पेशेंट को प्रोटीन, लो ग्लाइसेमिक इंडेक्स कार्ब्स देते हैं, एंड शुगरी, फ्राइड एंड ग्रीसी फूड अवॉइड कराते हैं इन फेज 3. आफ्टर प्रोग्रेसिंग फर्दर फेज 4 एंड फेज 5 हमारे पास आती है. फॉर फर्स्ट मंथ हम पेशेंट को कम्प्लीटली लिक्विड और प्यूरिड डाइट पे ही रखते हैं, सॉफ्ट डाइट के ऑप्शंस इनिशिएट कराते हैं. फॉर फर्स्ट मंथ पेशेंट जैसे जैसे उसकी टॉलरेंस इंप्रूव करती है who start adding more food, but the quantity should be less. Patient को जो चीज़ एडवाइस की जाती है कि वो अपने मैक्रो न्यूट्रिएंट्स का खास ख्याल रखे, जिसमें क्वांटिटी उसकी काफ़ी मैटर करती है. प्रोटीन की अगर बात करें तो हम 60 से 80 ग्राम्स उसकी प्रोटीन नीड एज पर बॉडी कंडीशन एंड हीलिंग हम देते हैं. लेटर ऑन कार्बोहाइड्रेट्स एंड फैट की जो ऑप्शंस हैं, आइदर कॉम्प्लेक्स कार्ब्स एंड फैट में हम हेल्दियर फैट को प्रेफर करते हैं. फॉर हाइड्रेशन हम पेशेंट को अर्ली स्टेजेस पे क्लियर लिक्विड डाइट एंड देन फर्दर जब प्रोग्रेस कराते हैं तो पेशेंट के लिए टारगेट होता है कि पेशेंट शुड यूज अबाउट 2 लीटर वाटर ए डे विच इज अबाउट 64 आउंसेस जो हम उसे पूरे दिन में देते हैं. बट पेशेंट शुड सिप स्लोली एंड अवॉइड फ्लूइड इनटेक 30 मिनट्स बिफोर एंड 30 मिनट आफ्टर मील. सो मील के साथ अगर वो पानी पीते हैं तो पेशेंट का जो इनटेक है वो मजीद डिस्टर्ब होता है. सो दैट्स व्हाई वी काउंसल द पेशेंट टू फोकस ऑन हाइड्रेशन एंड फूड एज वेल. लेटर ऑन behavioral tips for eating patterns matter a lot for sustaining weight gain, weight loss. Talking about different behavioral tips जो हम पेशेंट को देते हैं. Firstly, we focus on small frequent meal क्योंकि stomach का size छोटा होता है. Patient sometimes even eat 2 or 3 bites and patient is feeling full. So that's why small frequent meal, chew slowly. जब वो slowly chew करते हैं so patient can't overeat. लेटर ऑन पेशेंट को ये एडवाइस किया जाता है कि एट द फर्स्ट साइन ऑफ फुलनेस, जैसे दे आर अप्रोचिंग देयर सैटिस्फैक्टी, वी शुड स्टॉप ईटिंग फर्दर. लेटर ऑन देयर शुड बी नो डिस्ट्रैक्शंस लाइक टीवी, फोन एंड अदर डिस्ट्रैक्शंस. Lastly, during the surgical procedure and later on, patients are presenting with different nutrient deficiencies as well, जिसमें हमारे पास विटामिन डी, कैल्शियम, विटामिन B12 की डेफिशिएंसी काफ़ी कॉमन होती है. बिफोर सर्जरी इसकी असेसमेंट ज़रूरी होती है ताकि पोस्ट सर्जिकली हम पेशेंट की साथ साथ न्यूट्रिशनल सप्लीमेंट्स की मैनेजमेंट भी स्टार्ट कर सकें विद फूड. सो मूविंग फॉरवर्ड, यस, पेशेंट लॉस वेट अप टू 60% ऑफ एक्सेस वेट लॉस हो जाता है पेशेंट का इन फर्स्ट 6 months. अगर वो प्रॉपरली अपनी डाइट को फॉलो कर रहा होता है, पेशेंट जो है वो आफ्टर 1 month ऑफ सर्जरी फिजिकली एक्टिव होना स्टार्ट हो जाता है. इन फर्स्ट मंथ वी जस्ट रिकमेंड अबाउट वॉक, पेशेंट वॉक करे, हैवी लिफ्ट वेट वगैरह ना करें. इन सेकेंड मंथ पेशेंट मूव्स टूवर्ड लाइक डिफरेंट एक्सरसाइजेस विच आर लाइट वेट एक्सरसाइजेस. एंड इन थर्ड मंथ हम पेशेंट को मजीद एक्सरसाइज रिकमेंड करते हैं. एंड लास्टली, अगर पेशेंट सारे प्रोटोकॉल्स को फॉलो करता है डिफरेंट कंसल्टेंट्स के ओपिनियन के साथ एंड गाइडलाइंस के साथ एक अपनी पोस्ट बैरियाट्रिक मैनेजमेंट करता है, सो पेशेंट कैन इजीली मेंटेन 50% ऑफ देयर वेट लॉस. Lastly, moving towards this last slide, fast foods are the fastest way of taking you towards death more quickly. So it's patient choice and it's everybody's choice कि हम क्या चीज चूज करते हैं. अगर हम फास्ट फूड ऑन डेली बेसिस ज्यादा यूज करें विद इंक्रीज अमाउंट ऑफ अनहेल्दी फैट, सो हमारा वेट गेन करने का जो रेशो है वो बहुत ज्यादा होगी. सो दिस इज दी थिंग जो हमें पेशेंट्स को रिकमेंड करनी होती है कि दे शुड ऑप्ट ए हेल्दी लाइफस्टाइल. यू कैन ईट फास्ट फूड बट उसकी क्वांटिटी कम होनी चाहिए एंड उसका लाइक वंस ए वीक और आफ्टर 2 weeks आप यूज कर सकते हैं ऑन डेली बेसिस. जो है ये फिर आहिस्ता आहिस्ता हमारी जो फीलिंग ऑफ फुलनेस एंड हैप्पीनेस है वो फास्ट फूड के साथ लिंक हो जाती है. We are not performing well in our daily life, so that's why we opt in unhealthy lifestyle patterns which are leading us towards obesity, and then further different surgeries are recommended to get rid of those obesity. So lastly, thank you so much everyone for listening to me.
Thank you, Samra. Samra is a part of our bariatric team and she's a great help. So this was the last talk of this symposium. So I'd like to thank you, all the participants. And the number of bariatric procedures is increasing, and more surgeons are aspiring to be bariatric surgeons and generate local guidelines and provide them academic support. We need societies. So such a society has been established with the effort of our senior bariatric surgeon in Pakistan. That is Pakistan Society of Obesity and Metabolic Surgery (POMS). We are privileged to have the office bearers of the society in this symposium. So Professor Farooq Afzal, Dr. Nazir Hassan, Dr. Tahir University, they're all office bearer of the society. I'll request Dr. Mausud Hassan, a renowned bariatric surgeon, who gives the overview of the society and how it can help our young resident and surgeons in the fields of bariatric surgery. Mausud Hassan, please introduce the society.
Bismillahirrahmanirrahim. First of all, I'd like to thank Professor Daisy and Professor Farooq Rana and all the management of Hameed Latif that it's the first workshop regarding obesity in this hospital. And I've been working with obesity, I think, since last 10 years. We started in 2015 at Hameed Latif. And up till now, I think more than 1,500 procedures have been done here in Hameed Latif Hospital. I was in US and just came back yesterday. And I was away for 5 weeks. And I finished yesterday morning at 4 o'clock. We had 13 cases yesterday at Shalimar Hospital. And I woke up at 11:30 and just came. So, excellent talk by Professor Farooq Rana, Dr. Tahir Yunus, Atisha, Professor Daisy, and Dr. Fawad. So you must be aware of the disease and it is progressing all over the world. We have got different options, and most important is how to select our patient, and that's why we need to have some body for that. Because there are a lot of people who are doing bariatric surgery and practice bariatric surgery all over Pakistan, all district surgeons and all youngsters, they want to be a bariatric surgeon because they want that it should be done in like a small hospital in their cities. So everybody who just comes to me, I'll just tell you one story. A doctor from Peshawar, he came to me and he assisted me for 4 hours, 5 hours at Shalimar Hospital. At night, somebody told me we were having dinner, as there were 4-5 guests from Peshawar, and he told me, sir, look at the status of his like WhatsApp status. His WhatsApp status was with my picture. He said, Dr. Fana, General Metabolic and Bariatric Surgeon from this, or I've got my training here. So that's the way what people are doing. So what we want, that we should have a proper body, and we have been discussing that, and we had a society before, but there was a problem, but now we have registered another society, and all the senior members are on board. We will just elaborate how it functions, and all of you are welcome to join the society. We have got different options for the youngsters, for the growing surgeons, for the physicians, for the dietitians, and we have got collaboration with international bodies. Like IFSO, we have got with ASMBS, and we are trying to have with IBC, this one, UK. So I'll just elaborate like how we have formed our society. Previously, the first society was Pakistan Society of Bariatric Metabolic Surgery, President Professor Mumtaz Meher. But because of issues, it was not a society, it was an organization. So if so, for the technical reason, they wanted us to have a society. That's why we made a new society, this Pakistan Obesity, Metabolic and Surgical Society. Professor Dr. Tahir Yunus, he has done an excellent work, and he is the main backbone of this, like all this work which has been done by registering us with IFSO and with all other societies. And I'll just show you who are the members, so Professor Mumtaz Meher, he is now patron, and Professor Farooq is Senior Vice President, I'm also Vice President, and Dr. Ghulam Sadiq from Shifa, he is the President. Dr. Tahir Yunus, he is the General Secretary. So why we just selected? Obesity is a growing epidemic in Pakistan. Obviously, it's mismanaged and obviously ignored. We need a unified national voice. We need education, training, and ethical treatment. We need collaboration across medical specialties. So that is our vision and mission, to be the national voice for prevention of obesity and understanding the obesity and the metabolic disorders. Everybody says you just finish your diabetes. There are a lot of YouTubers just in 30 minutes, just in 20 minutes. You must be seeing a lot of ads on YouTube. So just you can say definitely It finishes diabetes, but not for everyone. That's why I tell everybody, don't ruin your life just by getting surgery if you are not overweight. If you are people who are doing surgery, of those patients who are just 60 weight and BMI less than 27, even people they have done very malabsorptive procedure like SARDI in patients who have got a BMI of 25 just to cure their obesity. So it's very important to understand when not to do these surgeries. So our mission is to promote obesity awareness. That is the most important thing. So who is doing, where you are supposed to send your patient, how much experience he is. It's not if you have done 4 or 5 cases or 10, 20 cases, you can do all these things. He should have at least hundreds of cases, then he should perform. Everybody should do, to start with, sleeve operation. He should do a sleeve gastrectomy. Here people are jumping up to metabolic, the malabsorptive procedure like bypasses. So it ends up with a lot of complications. So we need to advance bariatric metabolic surgery, foster collaboration, advocate for better public health policies. So main objective of this form is recognize obesity as a disease, improve patient outcomes, encourage multidisciplinary teamwork, lead national education and research, allocate ethical practices and funding, remain non-commercial and non-political and non-religious. Key focus areas: awareness campaign, education and training, research and publication, ethics and membership, and multidisciplinary collaboration. So we have got a lot of teamwork in forming this society, and Dr. Tahir has formed number of groups, number of teams which will work on research. Somebody will research on prevention, and some like ethics committee, like our programs. So it's a very comprehensive work has been already done. So leadership, founding president Professor Mumtaz Meher, and now the president is, he's now patron-in-chief, now president is Professor Ghulam Sadiq, vice president Professor Farooq Afzal, and myself, and Professor Dr. Tahir Yunus is the general secretary. We need to have chapters and committees. Each chapter includes education and training, research and publication, public advocacy, and ethics review. Who can join our society? Eligibility criteria: medical professional involved in bariatric and metabolic care, surgeons, endocrinologists, dietitians, psychiatrists, committed, ethical, collaborative, and evidence-based practice. That is the most important thing. That we should know when we are going and who is the one on which we are doing this surgery, because a lot of patients who have done sleeve gastrectomy 5-10 years back, now they are gaining weight. That is a big challenge to all the surgeons. We should know whether when we are going to operate upon them, whether we are going to prescribe medication and all, should they be eligible for surgery or not. So it's very important to understand the physiology and this biostatics, who are the patients who fulfill that criteria. So we need public awareness drives, capacity building workshops, national and international research, seminars and conferences, collaboration with IFSO, ASMBS, IBC and all other international societies. Core of conduct: uphold highest ethical standards, ensure patient confidentiality, promote professional unity, ethics committee handles disputes. We didn't have national registry up till now. That's the most important thing. All over the world they have got a national registry. It means that anybody who operates on bariatric patient, he should fill his data in that registry, so that in the end we can formulate our research. We should know what are the complications at different centers, what are the outcomes. So that is the very important thing what we are missing in our country. Dr. Tahir, he has done a lot of work on it. So we are blessed to have him here in Pakistan. He is an excellent academician, teacher and great surgeon. So inshallah, you will see in few years that we'll come out with our deficiencies, what happened before. So these are the financial, legal and transparencies thing, funding sources, memberships, donations, even sponsorships, annual independent audit and non-profit under Pakistan law. Future goals: launch national bariatric registry, that I already told you. and create accreditation and training programs, strengthen our chapter activities, build international partnership, and also we need to have fellowship. Already we are on it, and it's been starting now at Evercare, 1 year fellowship, and we will be having different centers, maybe at Shalimar also, and we will have, and maybe in Islamabad also, and maybe in Karachi. So we'll announce that when we establish, and we have to negotiate with all fellows, what are the criteria. At least they should have 1 year learning what are the basic principles of laparoscopic surgery, and then the bariatric surgery. Once you're a good laparoscopic surgeon, only then you are a good bariatric surgeon. But if you are a good bariatric surgeon, you are the best laparoscopic surgeon, because you do suturing, you do anastomosis, you do mobilization of every part of the body. So you are playing with the gut every time. So your skills, your suturing, it improves a lot. So that is, if you are a bariatric surgeon and you bypasses, so your skills improved a lot. You're doing 5, 6 cases, 7 cases. Daily you are doing stitching. Intracorporeal suturing is very important. Sometimes if you're doing gallbladder, you end up it happened, a patient who had a cancer gallbladder, and it was very stuck, colon was stuck over there, and while mobilization there was injury to the colon. If you know suturing, if you stitch it, you don't need like to do a colostomy and that. Stitching is very important. So laparoscopic skill, you need all these measures. So that we wanted our resident, our juniors, they should learn all that stuff before coming for their practices. If you practice well, you earn well. If you learn well, obviously it ends well with the safety of your patient and for your own safety. That is very important. वो कहते हैं उस्ताद अच्छा होता है तो शागिर्द अच्छा होता है. उस्ताद ऐसा होगा तो शागिर्द भी ऐसा ही होगा. It's very important कि आपने किससे सीखा है. We have been trained. That is, इस तरह नहीं आपको आती, बाकी आप मेहनत करते हो. ये नहीं आपके यहाँ लोग कहते हैं what happened जी आज करो तो आगे next day जी वो आके bariatric surgeon बन जाए. मैंने आपको बताया वो आते हैं, just they come for 2-3 days and they start advertising. फिर काफ़ी they end up with injuries. But the most important in bariatric surgery कि you lose your patient. That is the most important thing. If you are not well trained, patient can die. दूसरे patient नहीं होते. We can have complication. What you can talk about youngsters जिनको भी कुछ भी नहीं किया हो. तो मतलब it's very important कि at least your surgeon he should know how to handle this complication. That is the most important thing. तो ये इस तरह नहीं होगा. Team work is very important. You cannot work independently. मैं सब कुछ, you should have a proper team. You should build up your team. That is the most important thing. So this is a call to action. Are you healthcare professional, passionate about obesity treatment? Do you want to shape the future of bariatric and metabolic surgery in Pakistan? So join POMSS today. Thank you very much.
Thank you, Professor Maudul Hassan, for giving a very detailed overview of the POMS and its role and its opportunity. The youngster can join this society and its great learning resource. So the last part of today's symposium is the focus are the postgraduate resident. So luckily there were 2 patients in our follow-up who were looking for the bariatric surgery. So our resident will present their history and the patient will be with us, and our panel of experts will be giving their opinion to what should be the most appropriate procedure for these patients.
So today we will discuss MDT on the management options for the patients in morbid obesity. So case 1, about the patient whose age is 25 years, female, and her height is 5'9", weight is 147 kg, and her BMI right now is 45.5 kg. So it basically classify in class 3 obesity. Her ASA is 2. So her comorbidities includes hypertension, osteoarthritis, sleep apnea, backache, GERD, but she has no diabetes or dyslipidemia. Patient chief complaint is that the patient come to our surgical OPD for consultation of bariatric surgery with the history of overweight since birth and has long-standing history of obesity, weight of 90 kg by 2011, only the 5 lower segments is salient section. Her weight progressively increased to 137 kg by 2022. The patient regularly consumed canned and fast food, carbonated beverages, and sugary treats. She developed multiple obesity-related comorbidities include, as I said before, sleep apnea, osteoarthritis, backache, GERD, and hypertension. So our patient also goes through upper GI endoscopy, which shows mild gastritis, lower esophageal sphincters competent, esophageal mucosa normal, no hiatal hernia. Her weight loss history with diet and exercise has been achieved by weight loss down to 118 kg through gym and dietary interventions, but discontinued after reaching a plateau. Subsequently, she regained weight currently at 147 kg. History not suggestive of any psychiatric illness like depression, compulsive eating disorders. So our question for MDT is about which bariatric procedure should be offered for this patient for weight loss. So we can have questions.
Yeah, we have a chat GPT. Just put these parameters into the chat GPT and they will give you the answer. Yeah, I'm serious about it. So it's not basically what you basically are going to decide. It is the patient basically. So your job is to tell the patients that if or not your bariatric surgery is indicated, number one, and number two, what is your aim or goal about it? If there is a bariatric surgery, what is your aim or goal? It's just only the weight loss, or she's more interested in the metabolic profiles. So everything has to be encountered, and then you're going to say, yes, this is the one, it has this option and this pros and cons, this operation has this pros and cons, and this patient has this. One thing which I can see is metabolic profile, so she's not diabetic or something. So yeah, so I probably would have a lot of agitation considering prescribing her alloplasty procedure for her. So I think again the patient, what is her targets and what she wants to have. There's a sort of a shared decision making rather than me deciding about it.
Another cause.
Definitely, Farooq sir, what he's saying is right, but all we want to know the wish of the patient. Now what happens, patient comes, already they are aware of different surgeries, yes, and they just come and say that we want to have this surgery. वो कहते हैं डॉक्टर साहब भी हमें हमारी स्लीप करो, कहते हैं हमारा नहीं बाईपास करो, हमारे MGP करो. So what you are educating to your patient is the patient will stick on that. But we need to tell our patient what are the complications, problems with sleep, what are the with bypass. But now what we have seen, there is a lot of regain after sleep. Yes. So all those who got a BMI more than 40 or 35, sleep is not going to work after like 4 or 5 years. You may regain. Again, even your pouch is good. Because there are a lot of patients who are not following that, their compliance is very poor. So we always have so that they should have a better weight loss. And they should have a controlled weight loss later on. So nowadays anybody who have got like these things, but we need to tell them that you are supposed to be aware of your nutritional complications. because you can have like iron, vitamin D, this calcium, magnesium, zinc, vitamin B12 deficiencies. So they need to take these medicines regularly. If they are going to take these medications, then you offer them malabsorptive procedures. If they are very poor, they cannot take. It's very important their socio-economic status. If I've seen patients, like there are a lot of patients over 200 kg, you had a malabsorptive procedure, later on they didn't take the medication, so it ended up a disaster. So most important is their status. If they are affording, they can get those medication, then malabsorptive is best. Otherwise, go for sleeve. Even with sleeve, after like even 4-5 years, if you stop medication, everything goes with the regain, pouch size increase, so absorption increases. So they don't require after that, after if their pouch size increases. So that's why that is the most important you have to discuss with your patients.
So it's an excellent presentation. Actually, it's a good history that you presented. That there are a few elements in this history that we need to look into when we're making the decision. Like for instance, the good thing is that she doesn't have esophagitis or any GERD features. So it means that we're not restricted by which kind of procedure we're going to offer. That's the first thing. The second thing that you mentioned is that she lost almost 30 kilograms with diet and exercise. So if you calculate that, that's about a 20% weight loss that she achieved. So that means she's a good responder. Okay, so normally people lose between 5 to 10% with diet and exercise. She lost 20%, but we do know that the biology is still working. So it brought her back to where she started. So she couldn't maintain that diet and exercise because obviously as she's losing weight, the body tries to bring it back to the original weight. But she's a good responder. So it means that the response level to any therapy we will offer will be above average. Okay, so the response therapy to sleeve would be 20 to 25%, but looking at her, she would probably like to lose 40% of her weight. So she wants to go from 147 to let's say 87, that's 60 kilograms, so that's 40%. So she wants to lose 40%, so a sleeve would only give you 20 to 25%, but being a good responder, she might be 30%. But still, there's a gap, 10% gap. You can either fill that 10% gap with medications, so you give what you call GLP-1s with the sleeve, and she might be able to achieve her goal, but she will be GLP-1 dependent. Okay. The alternative is you go to a gastric bypass. Gastric bypass would be an option, but she would lose around 30%, maybe because she's a good responder, 35%, and with her diet and exercise she can reach that same 40% as well, without the requirement of any GLP-1s. But you tell her that she has a 1 in 3 chance of having dumping syndrome with any sweets, which is good because she won't eat any high glycemic index foods. It'll help her prevent her from eating high glycemic index foods. But it's a lifelong problem that you're facing with gastric bypass. And the third option would be a SADI bypass, where she would go directly to 40% weight loss without the requirement of diet, exercise, or medications, without the possibility of dumping. So doctor, I'm a Pakistani patient. I'm confused. Tell me what should be done.
Okay, that's an excellent point, because you're right. When we're talking to our routine patients, which is not the medical backgrounds, so you have to be very, very simple.
I want you to tell me, this is my
So I would give 2 options. आपके पास 2 ऑप्शन हैं. एक ये कि आप स्लीव गैस्ट्रेक्टमी करा लें, छोटा ऑपरेशन है, जल्दी रिकवर कर जाएंगी, बाद में लाइफ में बहुत ज़्यादा इम्पैक्ट्स नहीं है, लेकिन वेट लॉस एक एवरेज सा होगा, आपकी बीमारियां दूर हो जाएंगी, उसमें आप थोड़ी एफर्ट करके अपने और कंट्रोल कर लें, हो सकता है दवाइयों की ज़रूरत पड़ जाए. दूसरा ऑप्शन ये कि आप गैस्ट्रिक बाईपास कर लें, उसमें आपका वेट लॉस भी ज़्यादा होगा, वापसी भी के चांसेस भी कम होंगे, लेकिन उसमें आपको ज़िंदगी भर की एहतियातें करनी पड़ेंगी खाने पीने में, कि भी उसमें बहुत ज़्यादा मीठा वगैरह लेने से आपकी शुगर लो होने के चांसेस हैं. सिंपल.
I would do a sleeve on her because she is a highly motivated patient, and I have seen in my experience that well, these are averages, but there are people who are at the extremes of the two ends. So I think she will get a lot of benefit from sleep because of her motivation. I take bariatric surgery as a journey, right? So the initial passion is so important for that journey. So those people who have she's very inclined to lose weight. She has done her best to lose 20 kg. So this means with sleep and some medication probably would be the best initial choice for her, which will basically take her off from the fear of having malabsorption and taking dumping and other things. I think she will be comfortable with this sleeve. This is my opinion.
I will go for mini gastric bypass because मैंने भी देखा कि nowadays there are a lot of people जो gain बहुत ज़्यादा है. Even pouch ठीक भी हो तो आपका weight regain होता है आपका. So it's better कि आपने why do undergo surgery again and again. और दूसरा medicines are expensive. There are a lot of side effects nowadays. तो आप एक ही दफ़ा अभी जो ASMBS की consensus statement आई है recently just a week back they said bariatric surgery is 1,000 times better than medication in terms of side effects what they are having right now because अभी उनके side effects long term और आएंगे. अभी तो 2 साल हुए हैं यूज़ करते हुए. तो ये मतलब इसमें आप बाईपास रिस्ट्रिक्टेड बाईपास ऐसा करोगे आप बहुत ज़्यादा मैलअब्जॉर्प्टिव प्रोसीजर उसको ना दो. गट आप 150 40 50 तक रखते हो तो ठीक रहते हैं. अगर आप 170 80 तक रहते हो तो मैलअब्जॉर्प्शन ज़्यादा होती है. तो इफ़ यू रिस्ट्रिक्ट टू दैट लेंथ तो वो ठीक बिहेव करते हैं. वो उनका मतलब दे डू वेरी वेल. और वाइटामिन खाली आपको वो अब तो एक आ गई हैं सिंपल बेरेटिक वाइटामिन भी आ गई हैं जिसमें सारे वाइटामिन A D के साथ आयरन सेपरेट लेना पड़ता है और कैल्शियम. तो उससे आपकी 2 दवाइयाँ खाओगे तो चीज़ें आप ठीक रहते हो. बाकी लाइफस्टाइल अपना ठीक रखो. दैट मतलब व्हाट आई हैव सीन इन माय प्रैक्टिस नहीं वो अब सस्ते आ गए हैं. अब खाली 4-5 हज़ार के हैं महीने के.
बस आप कोई डिस्कस करना चाहते हो तो हमारे बोर्ड का फैसला है कि या तो स्लीप एस्टेक्टमी कर दें और उसके साथ हो सकता है आपको दवाई लेनी पड़े और एक छोटा बाईपास होता है मिनी गैस्ट्रिक बाईपास जिससे वेट लॉस थोड़ा ज़्यादा होएगा. वही आप कह लें कि 30-40 kg आपका वेट लॉस से एक्स्ट्रा लूज हो जाएगा. उसके साथ वेट नहीं गेन जो दोबारा वेट बढ़ता है वो कम होता है. जी सर. वेट के आपसे दोनों प्रोसीजर में से एक प्रोसीजर के बारे में फाइनल करके इसको. जी सर. जी सर. पूछना चाहती हूँ? नो सर. थैंक यू. नेक्स्ट पेशेंट.
हाँ जी सामने हाँ वो ना हाँ वो तो वापस दे दीजिए ना उसको.
So next patient is interesting patient because that's the one of the indication we don't discuss.
नहीं अभी नहीं करना है वो उसने.
Patients are referred by the orthopedic surgeon for knee replacement and before organ transplantation and they are referred by the cardiologist for heart failure. So this patient is on dialysis for the last 5 years and he is seeking kidney transplant but being refused by the kidney transplant surgeon because of his morbid obesity. So now he has been referred to us for consideration of bariatric surgery so that after weight loss he can be a suitable candidate for kidney transplant. History will be presented by the resident in detail.
So our patient is 43 years old, Seattle resident, with height of 5'9" and weight of 123 kg. This movement and BMI with 50.7 kg. So he is classified in class 4 obesity with ASA of 3. So with comorbidities, the patient has hypertension, diabetes, PSRD, on diabetes, 5 years hyperuricemia, but the patient have no symptoms of GERD, osteoarthritis, and obstructive sleep apnea or dyslipidemia. So the patient history is he is non-diabetic for 4 years and is on insulin therapy. He is obese for years. He has sedentary lifestyle with poor dietary habits, frequently consuming fatty and sugary foods. About 6 years ago, he tried to lose weight with diet and exercise, but was not successful. In 2023, at 156 kg, he developed orthopnea, oliguria, pedal edema, and numbness of hands and feet. 5 years ago, he was diagnosed as case of PSRD
and since then he is on dialysis. Sir, due to diabetes, diabetic nephropathy. So he was also referred to endocrinology department for weight loss and diabetic management. He was referred for endocrinologist for endocrinologist put on Ozempic for 2 years, having documented weight loss of 23 kg, 156 to 133. But according to patient after dialysis, the results of the Ozempic were not so good. History not suggestive of major psychiatric illness like depression, compulsive eating disorders. Patient is in regular follow-up for nephrology department on dialysis. Patient was referred for renal transplant but being deferred because of morbid obesity. Now referred to our team for consideration of bariatric surgery. So our question is which bariatric surgical option is best appropriate for obese patient with CKD to optimize their tendency for renal transplantation.
Sleep.
We go for sleep. We don't want to add but they are electrolyte imbalance So sleep is good. We operate many patients with CKD and even patient weighing 150, 175 kg. So sleep is better for them because there is disturbance of them. Like we don't have, like we have to work harder if we go for bypass.
I would go for a low and bypass. The best option for preventing his new kidney from failing from diabetes. Because the diabetes killed his last kidney, we need to stop the diabetes from killing his next kidney. And he's still within 10 years. So within 10 years of being diagnosed with diabetes, the outcomes of a Roux-en-Y gastric bypass are remarkable for remission of diabetes in the long term. And you don't get those results with the sleeve at all.
I have the SGLT2 inhibitors available. I mean, why do you want to add malabsorptive procedures?
It's not malabsorptive.
I mean, this patient probably would have a high risk with
A Roux-en-Y gastric bypass with a 50 centimeter biliopancreaticum is not malabsorptive at all. There are multiple studies that show that there's no malabsorption with a Roux-en-Y.
supposedly if it is like your brother.
I would definitely do a Roux-en-Y gastric bypass.
Probably I would not do it because SGLT2 inhibitors with the presence of rays, I think CKD has revolutionized, especially those with diabetics. So diabetics having this drug probably has so much impact. I think still we should go for if you think of the complications, sleeve has a few complications as compared to a gastric bypass. So I mean this patient is already having a risk because he is being prepared for a renal transplant or probably he will be a candidate for renal transplant. So in such situations we have to think of the recipient, the transplant he would get it. So a malabsorptive procedure for such patient would be, to my opinion, would be not suitable.
I mean, a mini bypass, you're bypassing 150 centimeters. But if you do a Roux-en-Y gastric bypass with 50 centimeter biliopancreaticum, there's no malabsorption at all.
So, thank you very much. I think both are valid options considering the impact of diabetes and full-blown CKD and dialysis and consideration for transplant surgery. So the Roux-en-Y gastric bypass has slightly more complication than the sleeve, but on the other side, as the Dr. Tahir is advocating that with a smaller BPD limb, he can be having the weight loss plus diabetes control and a protection for the future kidney transplant as well. On the other side, for such a patient with comorbidities, sleeve gastrectomy is a straightforward procedure with less resection and less problems. So both are valid option with its own pros and cons.
Can I say something? Just a
yes,
sentence.
Sure.
I mean, over a period of time, I did my fellowship in 2006. Over a period of time, I have seen not only growth in bariatric surgery and obesity surgery and metabolic surgery, but simultaneously improvement in medication for diabetes.
So there is like a parallel growth in diabetic medication. So now diabetes right now is far better managed as compared to diabetes maybe 10 years or 15 years, because we have much better options for diabetes medically. So there is, I think, a parallel growth of this. So that's the reason I think that we should.
We really enjoyed the MDT discussion and diversity of opinion from the experts. So this is how the great learning experience for the resident. For vote of thanks, I will request Dr. Hassan. He is the Chief Operating Officer of Hameed Latif Hospital, and I like to acknowledge their support for this symposium. We were actually, to be very honest, thinking to get the sponsorship of some pharmaceutical, but when the management of the Hameed Latif Hospital come to know that we are going to organize the academic symposium, so they wholeheartedly supported us and sponsored this whole symposium and all arrangements. So I'm very grateful to Dr. Hassan and Dr. Yusuf Latif, who is actually the owner of this institutions. So for vote of thanks, I request Dr. Hassan, who is the Chief Operating Officer of this hospital.
Thank you very much, sir. Very much needed, I think, symposium, and it was the talk of the town for the last 1 week. And you leading it, Gadi Sahab leading it, I think we all were very excited to participate as management. Hameed Latif Hospital में ये ट्रेंड जो है, ये गदे साहब इसके रूह रवा हैं, और अल्लाह ताला इनको इसी तरह से हमें गाइडलाइन देने की जो है ना, इनकी मौजूदगी हमारे साथ कायम रहे और गाइडलाइन हमें देते हैं. इनिशियल पार्ट सिम्पोजियम का मैंने अटेंड किया था, तो आई एम श्योर कंक्लूड भी हो गया. बीच में मैं देखता रहा लाइव थोड़ा सा, बीच में कुछ मेरी मीटिंग्स थी. बैटिक सर्जन्स बैठे हुए हैं. लकीली माज इज माई क्लास फेलो, वी वर टुगेदर इन भावलपुर. Never thought that you will become a bariatric surgeon. Surgery yes, but not bariatric surgeon. तो मैं ये सोच रहा हूँ कि आप सारों ने जो एक्सपर्ट ओपिनियंस दी हैं, प्रिवेंशन इज अ वेरी इंपॉर्टेंट पार्ट in every disease now. 40% of children of Pakistan are heading towards obesity. Lifestyle, food habits, I'm sure nutritionists बैठे होंगे, हमने बात की होगी. तो ना सिर्फ इलाज करना है सर्जरी से, मेडिसिन से, मेटाबॉलिक एंगल ऑफ द डिजीज़, बट आई थिंक प्रिवेंशन पे हमें घरों से भी शुरू करना है. अपने बच्चों को तरबियत देना और उनको बताना कि जी ये मामला जो हैं ये किस तरफ जाएंगे आगे. डॉक्टर साहब ने कहा डायबिटीज़ का इट्स वेरी वेल मैनेज्ड. स्टिल 33% विद 27% प्रेवलेंस रेट पाकिस्तान का. माशाल्लाह सबसे आगे हैं हम डायबिटीज़ की प्रेवलेंस में भी, बढ़ता जा रहा है. Because of the lack of probably the right kind of knowledge being imparted to a common man. और जो हमारे ट्रेडिशनल फूड और जो हमारे ट्रेडिशनल एक तरीका कार खाने पीने का रहा, उसको मॉडिफाई करके हमने इस तरह का बना लिया कि उसको रिप्लेस कर दिया है बर्गर्स ने और ये फास्ट फूड और इस तरह की डाइट्स, और बच्चे जब इस तरफ चल पड़े तो 40% ओबेसिटी बच्चों के अंदर आई थिंक इट्स अलार्मिंग नंबर. वो ना सिर्फ ये इन चीज़ों की तरफ लेके आता है, मेटाबॉलिक डिसऑर्डर्स की तरफ लेके आता है, एक बच्चे की शख्सियत को भी बड़ा मुतासर करता है. वो बॉडी शेमिंग और वो सारा जो मामलात और उसका सेल्फ कॉन्फिडेंस नहीं रहता. तो आई थिंक हमें एज अ नेशन भी इस पर सोचना चाहिए, एज हेल्थ एक्सपर्ट्स भी इस पर हमें काम करना चाहिए. और एक डायबिसिटी पे मैं सर से बात कर रहा था कि डायबिसिटी का एक हम एक सेमिनार जो है ना, एक सेमिनार क्या, एक सॉर्ट ऑफ एक्टिविटी, और वो मैसेज के बीच में क्यों ना की जाए. लाइक मॉल्स के अंदर अगर हम एक दिन का एक प्रोग्राम रखें सर, और आप लोग भी मौजूद हो और कॉमन मैसेज आके इंटरेक्ट करें हमसे, तो आई थिंक वी कैन स्प्रेड द प्रिवेंशन मैसेज एटलीस्ट. और जो करंटली सिचुएशन चल रही है, अगर BMI देखना शुरू कर दें लोगों का, वहाँ पे कैलकुलेट करना शुरू कर दें, और बेसिक उनकी टेस्ट डायबिटीज़ के हवाले से जो होते हैं वो करने शुरू कर दें, तो आई थिंक वो एक अच्छी एक्टिविटी होगी अगर उसको रिपीटेडली हम करते चले जाएँ. तो एज मैनेजमेंट वी आर अ पार्ट ऑफ यू ऑलवेज. और इसको मार्केटिंग के हवाले से, इस चीज़ का अवेयरनेस फैलाने के हवाले से आपके साथ हैं सर. हमें गाइडलाइन दीजिए, हम आपके साथ हैं. थैंक यू फॉर बीइंग हियर, थैंक यू फॉर कंडक्टिंग सच informative symposium, and lots more to come I think. और special thanks to Gadei Sahab, you all the participants, all those who have come from outside the hospital. A vote of thanks to everybody, all participants. I'm sure that you must be a little bit wiser today. थोड़ा सा इजाफा होगा knowledge में और तो inshallah lots of more to come, sir, in future with your guidelines, with your guidance and guidelines. Thank you very much. Thank you so much.
अमेरिका सर अमेरिका से चीज़ें देखते रहता हूँ भाई कहीं खुश होता है so happy for you boy.
Thank you so much for the invitation. I really enjoyed all the educational impact. WHO says social determinants of health, and I think we all should be knowing it. I totally agree with Hassan that it is the prevention that is important. Somehow the other, I was just talking to Gaderi Saab. My son wanted to go and play in the park, and all of a sudden some guards came and said, "You cannot play here." I said, "Why?" He said, "Because some women, they walk in the evening and the ball hits them." So I said, "Well, this is the reason why we're having too many couch potatoes coming up, right? So this has to be." So as a POMSS executive, it's also responsible, but it's a responsibility of all of our citizens to promote this prevention and healthy lifestyle. I think, yes, bariatric surgery is the extreme of things, but it has to stop somewhere. So inshallah, on behalf of the society, I assure you that our awareness program would be also focusing on good lifestyles and good diet. जो हमारी कार्बोहाइड्रेट डाइट है वो इतनी मज़ेदार तो बड़ी है, हेडोनिक हंगर, बट उसके साथ वी आर नॉट गेटिंग राइट प्रोटीन्स एंड स्टफ लाइक दैट. ठीक है, तो इंशाल्लाह नेक्स्ट टाइम विल फोकस, एंड आई कंग्रेचुलेट हमीद लतीफ एडमिनिस्ट्रेशन and Department of Surgery headed by a very capable senior professor, Professor Javed. He's one of our senior colleagues and teachers, and my friend Professor Farooq Rana, and the team of Tahir, and Tahir Yunus is an asset again, Moaz and all those. So thank you very much for giving me this opportunity, and well done. Yes, sir.
In the end, I'd like to thank my team lead, Professor Javed Gadezi, our Chief Operations Officer, Professor Tahir Chaudhary, our colleagues and part of Surgical Associates, and all the distinguished speakers, and my team who did a lot of efforts to organize all this team, in particular Dr. Adiba, who moderated this symposium. So thank you very much, and we wish in the future we continue a series of these symposia with the support of our administration. And now I think that's the end of this session. Thank you very much. Adiba want to present certain certificates. I'll request Professor Javed Gurdesi to be here. Professor Farooq Afzal, Dr. Hassan. I request first certificate to be presented to Professor Javed Raza Gurdesi by Dr. Farooq Afzal. Sir. Sir. Thank you, sir. Thank you. Next. So, मेरा अनपिक कर दो. The next certificate is presented to Professor Farooq Afzal by Professor Javed Raza Gurdesi. Thank you, sir. Fawad is not here. Tanveer is not here. So next is presented to our speaker, Dr. Tahir Ibrahim Yunus. Sir. Thank you. Dr. Mazul Hassan, please receive your certificate. Thank you. So our speaker, Dr. Samra Tahir. Sir. Sir, मुझे भी पेश. Thank you very much. Thank you, sir. और अदीबा का किधर है? कोई ले आओ सर्टिफिकेट. कोई ले आओ. Certificate presented to Adiba for the moderation and making all the arrangement for this symposium, sir.